Just before we get into the agenda, I just want to share with everybody, this meeting is being recorded and also live streamed on YouTube. With that information, I'm going to turn to Dr. Pratna BS, who is the strategic lead for the tuberculosis team at Team KHPT, to just introduce KHPT, its work and its vision. Dr. Pratna, over to you.
Thank you, Sukriti. Good morning, everyone, and I'm glad to be here today, especially talking about stigma and gender responsiveness in the National TB Elimination Program and TB programs in general. Coming back to KHPT, I think has been in around since 2003. It's a non-profit, non-governmental organization, and we basically started off as an organization working for HIV, and then moved on to address the social and the financial reasons why HIV was such a huge epidemic as it was in the last decade or so. And that made KHPT move into working with communities which were vulnerable to HIV, which were at risk for actually catching the infection because of the vulnerabilities that they were exposed to. And once we had actually gotten a hang of working with HIV, we've also realized that that holds good for almost all the diseases. So from 2011-12 onwards, we've also been working with other diseases like tuberculosis, maternal neonatal child health, and so on. And throughout the time, our DNA has been actually being in with very strong grassroots and community connect. We have also constantly believed in evidence-based programming, and also we've continued to believe that for any sustained programming to happen and function and leave an impact, government partnerships are a must. So this is roughly how our journey has been, very, very briefly speaking. Currently, we are working in tuberculosis. We are also working with, in a minimal, we continue to work with HIV and program, and we are also having programs with maternal neonatal health, nutrition, adolescents, and we have started off developing models for comprehensive primary healthcare, which is where the world and the nation is actually moving towards, with the establishment of health and wellness clinics and so on. Our focus has been to be as inclusive as possible, including and understanding, accepting, and recognizing the vulnerabilities that actually lead people to develop diseases, not to demedicalize diseases and programs, and take up the social aspects and the economic aspects which actually push people to getting these diseases and finally not having access to actually get themselves treated out of it. So this is roughly how KHPT has been functioning. Back to you, Sukriti.
Thank you, Dr. Pratna. Thank you, my pleasure. And we need to ideate, innovate, and be inclusive in everything that we do. With that, I would like to turn to Dr. Nishant Kumar, Joint Director, Public Health, Central TB Division, Ministry of Health and Family Welfare. Sir, it's a pleasure to have you here. Thank you for taking the time. I know your team has also joined, and my thank you to both Sumita and Sophia for coordinating this with us. Sir, it would be wonderful to hear your insights about the call to action for Jan Andolan for TB elimination, especially from the the lens of addressing stigma and discrimination, and also if you could touch upon the national framework on a gender responsive approach, some touch points that you would like to share with us, sir. Over to you, sir.
Am I audible?
Yes, sir. We can hear you.
Thank you. Good morning to you all. And I think this is, I can see in frame all the people who have supported us in, making it, community-led response and developing the guidelines for, stigma. I can see Blessy Kumar, good morning. I can see Dr. Dalbeer Singh from GHSR. You have been, your support has always, helped us. I can see Uman who is there. So first of all, in these testing times, I hope that you is safe, your families are safe. And since you asked me to give a keynote and you have mentioned different areas which I have to touch upon. So as you are aware, India has shown considerable, progress in TB control over the last 2 decades. I'll go a little back. Implementation of DOT strategy and achieving the Millennium Development Goals related to tuberculosis. And can I request Dr. Nishant to please mute? Thank you.
Dr. Mishra, you're logged in from 2 networks. Could you kindly mute?
काम करने का freedom, काम करने का freedom.
Dr. Mishra, could you kindly mute?
We can do it at our end. Just give
Yes,
us a
Team
moment.
KHPT, please, if you could mute.
नहीं तो बात है. अब देखिए हमको बोले गोरखपुर.
I'm sorry about this.
हमको सर डायरेक्ट नहीं बोले.
Can I please?
Just 1 second.
Okay, so thank you.
Yes, sir.
Yeah, so I mean, the whole effort was backed by the highest ever political, commitment and conviction. The country is boldly moving towards achieving the SDG 2030 targets, 80%, that is 80% decline in TB incidence and 90% decline in TB mortality by 2025, 5 years ahead of the global milestone. To achieve this ambitious goal, we are focusing on addressing the lot of things, we were told that almost 1 million cases goes missing. We have to scale up the TB care services in private sector, providing social support to TB patients, addressing the social determinants of TB through multi-sectoral approach apart from existing intervention within NTP program. Talking about these things, these issues raised about 5 years before. But you all are witness of our effort. With addressing these efforts, we could, able to reduce that gap of 1 million to, about 0.3 million in 2019. Then COVID happened. But then issues were addressed. Program was very proactive on these things, and also the notification from private sector also increased. So the point here is we took it as a challenge that it has to take into account the other factors affecting the disease. And basically we also try to we are working to address all the areas, social aspects and barriers that prevent TB from seeking care and completing the treatment. So achieving this unprecedented goal also calls for reaching everyone in the society with TB related messages and making every individual, family, organizations, workplaces as a part of the movement for TB free India. You are all witness, you are part of it, that Honorable HFM has launched the Jan Andolan in November 2020 as a people's movement that harness our strong political and administrative commitment and ties it to strength of all our stakeholders, which means you, who have ability to effect change from the grassroots. This is a meticulously planned approach that will allow us to tackle TB on all fronts. We have started this journey and we are continuing on this, and we are regularly, having meetings on that. So that itself, the highest level political commitment done in say 2018 and continuing, and now making it a public, a public movement led by our honorable, health minister. So this Jan Andolan aims to create awareness around TB through mass media campaigns, anything. I mean, the thing is, the bottom line is, you've been part of, these meetings. What HFM is very, very emotional about it. And he said, we will do it. We have to do it. We have to take, he said that the next year, the 2021 should be, remembered as a year where we put our energies to end TB the way we did in COVID, but then the second wave came. But still, we are still working on that. But just what I'm trying to say here is that the kind of commitment from the each level is there. So we aim to create an enabling environment for TB patients in their communities, an environment of acceptance where TB patients are not stigmatized in their homes, at workplace, or at healthcare facilities, by creating a high level of visibility of TB, emphasizing that it is curable. So the point here again is, let's talk about TB everywhere. Let's talk about it. Let's get it in the mainstream. We are all aware. This group has been working for quite some time. We think that we have reached the masses, but we have not. So this Jana Andolan, when it is operationalized in true letter and spirit, will achieve what we actually are trying to achieve for quite some time. The messaging around this campaign is most important. It must be positive and non-discriminatory. The source of messaging will be stakeholders, including community leaders, authorities at workplaces, frontline workers, and healthcare providers. We have to take everybody along. We aim to remove the myths and misconception around the disease and harness the power of community to take ownership of TB control initiatives, which will create an atmosphere of support at the grassroots. We aim to reach out especially to the vulnerable population who have different experiences with stigma and discrimination, to ensure that they have a non-discriminatory health-seeking and treatment experience with support from all the stakeholders throughout their treatment. And even thereafter, taking them along in this fight once they are treated, the way we are identifying people who have been successfully treated with necessary skill set to make them as TB champion, they join the fight and they, engage more people, so that the TB is high on agenda on existing platforms also, be it a village health and sanitation committee, be any health meeting, be it Rogi Kalyan Samiti. So that is the idea behind it. We have also, you are aware that we have also institutionalized the involvement of the relevant stakeholders at a local level. We have already formed a national TB forum. We have reformed it again. A meeting was held last year in September, 2019 September, but 2020 we all could not, meet again. Idea is that we are providing platform to the lowest level, that as of now to district TB forums, where local issues are identified, raised by the community itself, and then discussed, and the local solutions are presented to the table, and the local administrator, that is the DM, it should, and we have been very categorized. We have come a long way. The way initially it started, the district TB forums, it was like a regular program review meeting where we could hear something from one or two TB champions. But now we are evolving. A lot of issues are being discussed, and those issues are being resolved. We have a very good example from Kerala, Himachal Pradesh, and so we are. The point here is we have institutionalized it to give a platform where all these things can be discussed. You also asked to comment upon the stigma and discrimination associated with tuberculosis. See, the National Strategic Plan for Tuberculosis for elimination of TB has identified already, in that it is documented as a major barrier for ending TB, and had identified that if we are to reduce delays in diagnosis and improve the treatment outcomes, we must take all possible efforts to mitigate both stigma and discrimination within health system and society as a whole. We are working towards, making this whole cascade a very friendly atmosphere. For that, multiple strategies are being adopted by the program, be it giving soft skill trainings to the staff who are involved with the TB patients or presumptive TB patients in day-to-day life, and to kind of have an environment where both the community and the health provider are having a dialogue. Again, TB forum at district level is one such mechanism, but we have community meetings, we have mechanisms for that. So, and with this vision, CTD conducted a series of consultations with different stakeholders. Most of you are sitting here, including community representative and civil society organizations. I would call you all of you who are present today as TB crusaders. We have a TB crusader in Amrita Kumar from GCTA. We have Uman George from Abbott Associate. Dr. Dalbir Singh from GHS has always been so supportive in developing that document. I thank USAID, Union, KHPT, Alert India. So we took note of it that it is the biggest barrier now, and we try to come out with a guidance document which definitely states will improve upon as per their and implement, and it will help them how to do what is necessary to reduce stigma. It's not very easy to do, but then it's an attempt that we have tried to sort of give guidance to the states, and it was released by Honorable Health Minister on the last World TB Day. So the document recommends addressing stigma and discrimination on priority in 3 settings, which have the higher impact. Community, including the patient's family. It starts from there, which have, and the social circle of the patient, workplaces, and healthcare settings, and suggests specific strategy. This document talks about it, gives scenarios and what can be done. More things can be done, but it's a guidance sort of a document to the states. The document, while informs about program strategy to end stigma and discrimination associated with TB, it also intends to improve understanding on stigma and its impact and help to identify context-specific interventions in different settings and among specific target audience. So I thank you all, because we used to talk about, everybody knows that there was stigma associated since the disease is known, but and everybody knows it, but the state program managers and the people at district who were handling the program were not, did not have anything, any formal introduction to different aspects of stigma. So this document definitely will evolve again when we try to implement this, try to use this document. So since it's I think it's live on YouTube, I would request all the people who have logged in, to go through the strategy document, adopt the vision of stigma-free TB response, and align your current upcoming effort with, goal of ending TB. If some organizations have logged in, I would request, please go through this. It will guide you how to, actually implement this, and it will give you sort of idea how to address the stigma and discrimination associated with TB or any other disease. And you also talked about, you also asked me to talk about touch upon the national framework of gender response approach to TB. So India's national strategic plan, again, as the stigma is very well documented, noted, identified. So it talks about removing gender-related barriers to TB care and services as well. Gendered approach to TB care and prevention is the felt need. The program has developed national framework for gender responsive approach to TB in India. This framework describes interaction between TB and gender, outlines impact of gender on TB burden and response. It also defines actions to move toward gender responsive approach. The objective of developing the framework is to aim for equitable right-based TB services for all genders, women, men, and transgender person by adopting a gender-specific programmatic approach at all levels. So this framework talks about all these things. It is also to mobilize, empower, and engage women, men, and transgender person in TB response at the health and at the community level. The framework is for NTP staff at all levels. I mean, it's again a guidance sort of a document. Healthcare providers, civil societies, community representative offering TB services, anybody who is involved in TB elimination efforts can take guidance from this document. It also calls for action on gender sensitivity training. As I said, that we are already doing it, trying to getting the training load assessed, and then we will start it. Gender sensitivity training for NTP staff, the staff at the peripheral level, which are in day-to-day touch with the beneficiaries and the care seekers. The gendered approach would, again, it covers all. I mean, diagnosis, treatment, prevention. Every gender has some specific needs. So this training of sensitivity towards gender will try to address those needs, those specific needs. it's also essential that our communication strategies are tailored to different genders. So again, this is something which we have to work on. We need your support, and I think we'll work on this. We have set our exhaustive guidelines for civil society, the private sector, the healthcare facilities regarding program implementation, monitoring, evaluation, and research. And again, we urge these sectors to integrate these guidelines and initiatives. I think we'll need more workshops like this, so we can actually communicate what the program wants to do, and any suggestions and existing guidelines, we can definitely work on those. So in the end, I would end by saying that only way we can end TB in India is by making it a public movement. There are no two ways about it. And COVID, with all its bad things, what it has taught, that now people are receptive regarding health needs, regarding respiratory infections. It has the wearing of mask, which TB program was trying for so long, has become, and now we have accepted it. We came to know, general public at the last, my last area of the country are aware how respiratory infections, spread and how to stop them, right? Whatever we do for COVID, it works for TB also, as far as cutting the transmission is there. So public movement is the bottom word. We have to make it everybody's felt need. Even if they are not having TB, they don't have TB in their family. We cannot be TB free unless the whole country is TB free, unless all countries are TB free globally, to end it globally. We have seen this. This COVID has definitely affected all our lives, but then it has taught us some things to work on. So public movement, the way social media has spread the knowledge, sometimes knowledge also. But then the bottom line is TB should be talked about at each and every health forum. See, what do we need for all this? We need a political commitment. We need administrative commitment. We need the right technical guidelines. And you all are aware that these all are in place. There are no there are no doubts in my mind. There are no doubts in the health ministry's mind and all the staff who's working, that whatever is required. I mean, all the health programs I've seen, they struggle to get the political commitment. We have achieved that. So by we, I mean you and us, we have the program, we have achieved that. It has come high on the agenda. And I think we are on the right path. COVID did definitely affected all the programs, but it definitely affected TB. In much more, what do we say? We were on such a good path in 2019, what we did in 2019. We could see that the kind of momentum with civil society engagement, the state teams, the national team, the kind of synergy we have witnessed in 2019, I think had we gone like this, we would have been in a very better position today. So again, I would say we are on the right track. COVID did affect. We are motivated. We are still engaged with states and stakeholders. You are regularly interacting with us in spite of COVID. That shows us the commitment of all of us. So I wish you safety in these testing times. And again, I would say, TB harega, desh jeetega. Jai Hind. Thank you.
Thank you so much, Dr. Kumar, and thank you for the inspirational words. And, all of us on the screen, everybody who's logged in, we are here to support you every step of the way, work with you to get to the dream of TB elimination soon. So thank you again. And with that, I'll turn to Amrita Goswami, who's the project management specialist at USAID. Also, Amrita works with us, guides us, and thank you for that, Amrita, always. Over to you, just to understand, your perception of ensuring gender responsiveness and stigma redressal when it comes to tuberculosis, and USAID's fantastic journey, especially as such a close support to the government of India on this vision. Over to you.
Thanks, Sukriti. I hope I'm audible.
Yes.
Okay, great. Good morning, everyone. And again, on behalf of USAID, I would really like to thank everyone for joining us for this workshop on gender responsiveness and stigma redressal. I really hope that everyone and their families are keeping well and safe. Just at the outset, I want to congratulate and thank KHPT for organizing this workshop. Of course, Dr. Nishant and team, thanks to you for your constant support in helping us take the gender agenda forward in TB. Dr. George from, who is also part of the NTSU now at NTEP, looking very specifically at the ACSM strategy, also the revision of the strategy. So I think your inputs from Dr. Dalbir Singh, from Blessy, from Blessina Kumar, as part of today's workshop also will be extremely useful. I think just to start with, Dr. Nishant also really highlighted very well on how we are very acutely aware how the COVID-19 pandemic has really intensified many of the challenges, whether it's health, the socioeconomic and the security challenges that we are facing in India, that really men, women and the trans communities are facing. And once the pandemic began, a number of critical healthcare resources were redirected to manage the pandemic response. And obviously this resulted in a decline in the provision and the utilization of India's healthcare services. And obviously this included TB testing and treatment. Now coming very specifically to TB, Sukriti, I don't need to mention at this forum any of the statistics, but we all know how in our country, we have the highest incidences, not just of TB, but as well as the TB related mortality as well. And while in most societies, we can say that men may seem to have higher incidences of TB, but again, women, adolescent girls, trans community members, they really experience a number of social, cultural, and, very different inequalities in the provision, not just of TB services, but healthcare services at large. And these really have a huge impact on the overall health and well-being. And whether it's a fear of a loss of income, the consequences of absence from work that hinder care seeking in men, the women also may face a number of different difficulties due to the prioritization of chores in the family over their health. Or maybe it could be a lack of money, financial dependence, etc. Again, another very critical factor, and I know that as we go on through this workshop in the next hour or so, we would be talking a number of stigma-related issues and challenges that are linked with the health-seeking behavior and the entire treatment adherence factor as well. I think people often tend not to disclose their status within the family and outside the family, and they really worry about a positive TB diagnosis that will adversely affect not just their families, but also be ostracized from the communities and from workplaces, etc. I think, Sukriti, you did mention about how USAID is supporting. So I think in relation to the gender agenda, I would like to mention that we have at USAID a gender equality and a women's empowerment policy that really reaffirms our vision of how we look at really getting solutions to the inequities that men, women, boys, and girls face in terms of accessing any form of economic, social, cultural, health perspectives. And I think this holds very true for our TB portfolio as well. Addressing these challenges really require across our portfolio a very enabling environment, and at multiple levels, whether it's improving the reporting indicators on TB to policy changes to influence behavioral changes. All our programs at USAID really works on all of these levels via its partners. And our TB team at the health office is committed to work with all our partners, including KHPT and others, to consider these challenges that take gender into consideration, whether it's at the phase of designing or its implementation of the programs. And our projects aim to support these activities that include the identification and the correction of gender-based inequities within the TB portfolio as well, whether it's TB service delivery, etc. And Dr. Nishant also spoke about the guidelines, the strategy document on a gender-responsive TB framework. Just like to reaffirm that, a gender-responsive TB program needs to be one that acknowledges the different norms and the roles for men, women, and the trans people, takes into account a number of very specific gender needs, addresses the causes of gender-based health inequalities, including, includes strategies to kind of foster equal power relationships between men, women, and trans people. And this is really something to be kept in mind, not just by USAID, but also its partners and within the larger TB program that, when we design, implement, or evaluate any of our interventions, these are very critical steps. And at USAID, not just for TB, but for any program across the mission and for the agency, we conduct a gender analysis at a macro level. This is part of our country development and the cooperation strategy. And each program, in fact, at the activity level, have a tailored gender analysis to really target the geographies that we are looking into. Also, another thing is that we look at a very collaborative learning and adapting approach also while we work across the portfolio. Again, we are all aware that USAID has been working with the CTD, with the ministry, to really pilot and demonstrate a number of models which looks at improved and equitable TB care and treatment services, not just at the national, but also at the state levels. Dr. Nishant highlighted, and a number of guidance documents were actually released earlier, this year during World TB Day, and some of these have been made possible due to the support of our partners. So these, of course, include the strategy on stigma and discrimination, of ending stigma and discrimination associated to TB, the gender responsive approach, again, the collaborative approach of management of TB in pregnant women and others. And I think right now, as Dr. Nishant also mentioned, the critical, the important thing is to really operationalize the strategy, how through our work with our partners, we look at operationalizing the steps that are mentioned within these guidelines. And of course, for the entire Jan Andolan movement, our partners will continue to support CTD in conducting the activities at the different geographies. And I think even going beyond this entire emphasis of the topic, whether it's during the TB forum meetings at the state or the district levels, whether it's during the sensitization of the TB champions, etc., it is again something that we need to keep talking about. I really feel that part of today's conversation flow, during the next couple of hours, we will look at the gender dynamics and the barriers that exist, and really attempt for a very meaningful gender participation in all our TB programs. I think conversations like the one that we have are important to raise awareness and really to ensure the gender sensitivity that continues to be a part of our TB program. And like Dr. Nishant said, I think though we have made progress, we still have a long way to go. So whether it's to adopt further behavior change communication strategies that really look at correcting misconceptions about TB and its transmission, and help remove the stigma and the discrimination that is associated with TB, whether it's this or the increased awareness about stigma and gender amongst the staff of NTEP and amongst the medical professionals. We really need to look at it. Again, TB comorbidities, TB for people like, who are smokers, who are drug and alcohol dependents, who are pregnant women and postpartum women also, who are undernourished. We need to address all of these issues with them also. And really going forward, further building the capacity, whether it's the knowledge, the attitude, or the practices of all program staff to provide respectful, patient-friendly, and definitely gender-sensitive and gender-responsive services. What is really important, and Dr. Nishant also said, the political commitment, the administrative commitment, and the technical assistance, again, are the three pillars of any successful TB program. And I think as a USAID team member, I think all our programs need to look at how we can support CTD and the larger TB program on this. I think by addressing these pillars, we not only address TB, but also look at furthering gender relationships between the community and large, and move towards a more inclusive society. So I think with this, Sukriti, I'll hand it over to you. Thanks again to everybody for participating today. And definitely, I'm looking forward to the discussions in the next couple of hours. Thank you.
Amrita, thank you. And I think that's a very strong call to action and, the guiding light for the next, the next hour that we will go through. Just before we proceed, I can see we have close to 150 attendees logged in. And if you have any questions, please do leave it in the question box. And I'm going to make sure that I address it to the panelists from where you're seeking the answer. We are going to do that towards the end. I'm also going to take this opportunity to once again welcome all the STOs and the field teams. We all have a vision, as Dr. Kumar said, that, there are guidelines and pathways charted, but, you are the people who actually implement this. And, the real backbone of all the work we do is at the community structures. So thank you so much for all your support. I'm going to just also share with the audience that we have two videos, short ones that we'd like to play. It will also give us a break and, allow us to think differently. So I'm going to request the KHVT team to play the first video link. These are films which are released by NTEP. Thank you so much for the same, Dr. Kumar and team. Over to KHVT team, please play the first video.
Yes, please give us a moment while we share our screen and play the film.
So the purpose of the films, as Shramana is putting these up, is that, it highlights different kinds of stigma that TB patients may be facing. The two films that we'll play today, the first one is, a college narrative, and it's coming up on your screen now. Shramana, we can't see. Could you pause it and play it again?
पता है ना मुझे टीबी है। चल तुझे पता है ना इलाज का असर शुरू होने के बाद टीबी के इन्फेक्शन का डर नहीं रहता। टिफिन में क्या है?
Shramana, we can't see the screen, please.
You can't see the screen?
No, it's not loading. It's stuck. If you could try one more time.
Okay. Suchita, can I request you to play the film, please?
So while we figure this out, I think we can move to the next speaker in the interest of time, and we'll come back to this film after Dr. George's presentation. Dr. Oomen George, team lead NTSU TB-ACSM with the NTEP Ministry of Health and Family Welfare. Pleasure to have you with us, sir. I'll request you to share your screen at this moment. Dr. George is going to talk to us about, the stigma, discrimination focused on tuberculosis and overview. We all know he has over 30 years of experience working on these issues. And Dr. George, really looking forward to your presentation.
Thank you, Sukriti. Can I assume that everyone can somebody please confirm that you can see my screen?
We can see it, sir.
Great. Thank you very much again. Thanks to KHPT and USAID and CTD for facilitating this workshop, which I think is a very important one, and it really needs to go beyond just the implementing partners. And, as Dr. Nishant said, this needs to be spoken by everyone. It's a very challenging task to talk about stigma in 10 minutes. So I'm not even going to try to talk about everything. As the title says, this is just an overview. I know that Blessy is going to sort of add to this and definitely going to give value. Dr. Nishant has actually done half the job by introducing the importance of stigma in the program, but also in terms of TB elimination and underlining the fact that without addressing stigma, we cannot eliminate TB. We talked about three different things so far. We talked about gender responsive approaches. We talked about stigma, and we talked about equity. These three are so closely interlinked. And at this point, before moving on with the presentation, I just want to urge all the states that are here and all the other states as well to take forward the strategy to end stigma and discrimination associated with TB forward, localize the strategy and the plan to the state, but more importantly, localize it and come up with action plans for district level. Because as we've said again and again, and we'll continue to say, we cannot address TB or we cannot end TB without addressing stigma. Why? Okay, now I am stuck. My presentation, yes.
It's moving.
Yeah, now it's happening. So why is it that we need to address stigma? As we've just said several times, we want to end TB, right? The traditional way of looking at this was to go the clinical and public health route. So we thought many years ago, I'm talking about a couple of decades and more before that, we thought that if we empower providers and doctors and healthcare providers at the community as well as clinical facilities with adequate capacity, we'll be able to address the problem of TB from a clinical point of view, but then we've added a public health aspect and sort of added adherence support and notification and all that to that. So we thought that was enough. People will come and they have cough or fever or any of the symptoms, and we can take care of that at the medical end of it. That wasn't enough. And later we added what is the social arm of TB management. And here we thought that, okay, it's good enough to let's increase knowledge or improve awareness about TB and about its management with people. And that in addition to the service delivery should be adequate. That wasn't enough either. So we now have a TB management cycle that sort of supports each other. So there is a demand side and a supply side that we have to take care of. And this has to be very well balanced. Okay. So we definitely need healthcare providers who have adopted standards for TB care, both for diagnosis as well as treatment and follow through. And we want them to be able to demonstrate positive behaviors to the people they take care of. Okay. We want people to have enough knowledge and awareness about the disease and its management, but we also want the family, the friends and community of the people affected to display a positive behavior towards those with TB. This is very important that we address the stigma and discrimination that's associated with it. All this can happen through behavior change communication. This can, in addition to the technical and the supply side interventions, which includes drug supply, diagnostics, and so on, which are very, very important, very critical, we also need to have behavior change both on the supply side as well as on the demand side. The weak link here is the way people behave with people with TB. That's the weak link. We talked about equity or inequity, right? Now it's easier to do the other aspects because it's about putting in the money and putting in activities and ensuring certain activities are carried out with certain targets in mind. The social or the behavioral issues are far more difficult to address. Therefore, if you don't address this, the rest of it is only partially beneficial. So I cannot emphasize how important it is to address stigma, how important it is to address behavior change among people with who may have TB or who have TB. I'm reading this. This is a quote directly from the strategy document, the strategy to end stigma and discrimination associated with TB. Stigma primarily stems from fear of tuberculosis and of the disastrous health, financial, and personal and social consequences of the disease on affected individuals and families. Stigma exacerbates, it makes worse the medical and social hardships of TB. And it is responsible for delays in diagnosis and treatment initiation, and causes treatment interruptions and poor outcomes. Stigma is a barrier to TB elimination. As I said before, we can't emphasize this enough. What is stigma? Stigma, as most of us sort of understand quite well, it's a mark of shame. We feel ashamed. We feel disgraced. We feel that somebody is disapproving of us. And what it leads to is isolation. It leads to rejection by the family or at work or any other, or by the community, and it leads to discrimination. Keeps us out. And that is very scary. A few points about stigma, and specifically I want to come up, let you know of some, not all, there's a very small number that's mentioned here, of the evidence that we have around stigma. There's a lot of it. The first thing is stigma in TB is different from stigma in other health areas or other areas. Like HIV, for example, it tends to be quite overt. And I think people who work in HIV, HPT knows this very well. In the 90s and 2000s know that this was a horribly stigmatizing disease, and people were just scared to even mention HIV or AIDS in those days. Stigma around TB is different. It's latent, it's hidden, it's under the surface. It doesn't come out until somebody is known to have the disease. 3 out of 4 people in a study that was conducted, 3 out of 4 people showed stigmatizing attitudes. Almost everybody in that study showed that they had discriminatory attitudes towards somebody with TB. The main reasons for stigma were identified as fear of infection. What that means is there was fear of getting the infection because people thought this would never go away, it could not be cured. It was also thought that TB leads to death. So that's why people are really scared of the infection. There was also the fear of economic disaster. There were fears resulting from various myths, like TB is hereditary. It only affects the poor, doesn't affect the well of how can I get TB. That kind of thinking was, is always something that comes up. There's a belief that it affects people who do bad things, and therefore I'll be clubbed along with them. And then it's a social norm. Others are stigmatizing, let me also do it. Same thing. Stigma hurts women and children and men, but their stories are different. It hurts all types, all people, all genders. It hurts different walks, people from different walks of life, but people have different experiences, and these are well documented. Women tend to be more distressed, especially around marriage or family status. They tend to even get kicked out of homes, and this has happened in so many. I think many people on this in this workshop are aware of actual situations where that's happened, and it impacts childcare as well. More than 50%, nearly 6 out of 10 people hide their disease from friends and neighbors. And this is very critically important, that you don't hide the disease. I mean, you don't have to announce it to the whole world, but it's very important that you inform key people about the disease, especially those who care for you, so that you have access to care. And finally, a misconception. Improving knowledge should bring down stigma. That's not true. Studies have actually found that improved knowledge does not equal to reducing stigmatizing attitudes or behavior. This is very important when we're talking about interventions to address stigma. Okay, there are several types of stigma, which I'm not going to get into the definition because these are easily available for anyone who wants to look at it. What you need to understand is that stigma may be enacted by the community that a person lives in. So it could be from the general community or people that you have who know you and know that you might have TB. It can also be generated by people who are fairly close to us. It could come from work colleagues or family or friends. Stigma also originates in institutions, including health institutions. This is I know this sounds very worrying, but it can occur in health institutions as well. Medical health care providers can also stigmatize, maybe not intentionally. Not everyone does this intentionally to harm somebody, but it can happen. And importantly, it can also be self-stigma can also happen. It can be self-perpetuated. I'm going to sort of close this presentation with a look at what are the implications of stigma. And I'm going to do this using the continuum of care that we have, and that's now fairly commonly used everywhere. The continuum of care has 4 segments. There is the health-seeking phase, which is the green. You can't read this, so please don't try to. It's the green segments on the left. And then there is the clinical management phase. There's the care and support phase, which is the first segment on the right on the orange, and then the post-treatment phase. So if we look at these, the implications of stigma by the segments in the continuum of care, the first segment in health seeking, what it does is it delays health seeking, especially if the symptoms of that the person experiences are associated with TB. Now, this is scary because it sort of, on one hand, tells me as a public health person, don't talk about symptoms before people seek healthcare because that will keep them away. But that's again, that's again a problem, because if I don't know that I might have TB, if I have cough of 2 weeks or more, then I might not seek healthcare immediately, and that's a problem again. So it's a double-edged sword. We need to deal with this very carefully. But stigma, what it does is the fear of TB may actually delay health seeking. In the pre-diagnostic phase, that is after a person has sought healthcare, so while the person is in the system officially and gets told that what you have might be TB or is TB, there is a denial to that. I don't want to accept that I will have TB. I might have TB. I cannot get TB. How can I have TB? These are all the questions that people ask. What that leads to is a lot of unnecessary shopping. It means I'll go to the wrong people, wrong healthcare providers, and receive non-standardized healthcare. It delays diagnosis. It delays treatment initiation. And all this, of course, leads to increased and even catastrophic costs. And of course, the whole lot of consequences that would happen after that due to the delays, including increased sickness and death. Post-diagnosis, once I'm told that I have TB, I don't want others to know that I have TB. Okay, once I accept that I have TB, I'll say, okay, I'll take the medicines, but I don't want others to know. What results from this are missed opportunities for counseling and care and support. And this is a very critical part of TB management. Because if a person doesn't receive the counseling or the care that he or she needs, there is the threat of incomplete treatment or non-adherence, or what we call treatment rupture. If that happens, we know that there's a risk of drug resistance, greater increased sickness, more treatment, and death. Obviously, all this results in poor treatment outcomes, which is completely against what we want for. So when we address stigma, when we want to look at how to address stigma, we have to address it from these 3 segments. Of course, you'll want to break it down further, but these are the broad 3 segments we want to look at. Interventions at the community phase, interventions before diagnosis, while a person is, after a person is seeking healthcare, and interventions post-diagnosis. And this is, of course, a long phase, so there's a lot of interventions that are required. So you want to take away the fear that people have on one side, that is people who are affected, and on the other side, you want to reduce the stigmatizing and discriminatory behavior of communities, of healthcare providers, and of workplace people who are colleagues or supervisors or managers. I'll stop here with a strong recommendation that those who haven't been through the strategy to end stigma and discrimination associated with TB should do so at the earliest and start looking at how to apply the principles that I talked about, the interventions that I talked about, how to apply advocacy and communication and community engagement in their own areas of work. This is the only way we could even look at the possibility of trying to achieve the NTB goals of 2025. Thank you very much.
Thank you, Dr. George. And, in the end, when you said that we should employ these strategies, we should look at all our work through this lens, I hope all of us on this webinar walk away with that learning. And thank you again for that fantastic presentation. Before we move to Dr. Singh, I'd request Sucheta from KHPT to try and play the video one more time so it gives us a little bit perspective, and then we'll move to Dr. Singh's speech.
वही देख पवन आ गया। पवन वहाँ क्यों बैठा है? तुझे उसे टीबी है। और भाई लास्ट बेंच का मजा अकेले अकेले।
पता है ना मुझे टीबी है।
चल चल तुझे पता है ना इलाज का असर शुरू होने के बाद टीबी के इन्फेक्शन का डर नहीं रहता। टिफिन में क्या है? टीबी के दवाई के साथ खाना भी अच्छे से लेना है, समझा?
अपनों का जोड़ है टीबी का तोड़, तो फिर भेदभाव क्यों? टीबी के इलाज में अपनों का साथ दें।
Thank you so much, team. Apno se bhedbhav kyun? And with that, I'm going to move to Dr. Dalbir Singh. We all know of the amazing contribution Dr. Singh has made to the TB landscape in the country. And I know Dr. Kumar was talking about prioritizing TB and giving it the correct political commitment from the highest levels. And Dr. Singh, who's obviously established the Global Coalition Against TB, has been instrumental in close to 7 to 8 critical policy interventions which have made TB the priority it deserves to be. With those words, Dr. Singh, I turn over to you and we look forward to hearing your thoughts.
Let me at the very outset compliment Dr. George for the brilliant presentation. And in fact, after what is given threadbare on stigma, there is very little actually to be asked or raised so beautifully. I must thank you, Dr. George, for such an enlightening and such an eye-opening detail that you presented. Now coming back to our today's question of gender responsiveness, being a politician partly and a soldier with a soldier's commitment, I personally believe that in everything in life, it's the policy. Unless you have a firm policy in position, nothing will emanate from it. Whether the rules or whatever you frame later, it emanates from policy. And I'm very happy, and I must compliment the government to have finally come in 2019 and develop a framework which is gender responsive, because we have suffered such a lot over the years, and at every level people have been taking it up with the government. Now, because we are all committed to 2030 agenda on sustainable development, the government of India has also committed to eliminate all sustainable development goals. And on the floor of the parliament and even in the United Nations, we've given a commitment, we'll end TB by 2025, 5 years ahead of schedule. And let me tell you that this particular framework which has finally come, it also finds echo in what was discussed in the United Nations special resolution. I was present there, David Dr. Nadda and a number of parliamentarians, because the UN resolution says the various socio-cultural barriers to TB prevention, diagnosis and treatment, there is a dire need to develop integrated, people-centric, community-based and gender-responsive health services based on human rights, mind you, even based on human rights. And the countries must develop approaches that will protect and promote equity, ethics, gender equality, and human rights. And this particular session was done only on tuberculosis for one full day, and there was a participation by nearly 150 23 countries, and the health ministers and all the functionaries over there spoke very passionately, because TB has been troubling most of us, and particularly us. Even today, we have 27% of the global burden, 30% of mortality, and something that we lacked. We finally came with the framework, because although we accept that there are more men who are affected by TB, but women and transgender person experience the disease very differently. Gender differences and inequalities play a significant role in how people access and receive healthcare, and also in various sectors, public sector, private sector. And also there is adequate evidence to indicate that gender is significant influencer of epidemiology, risk factors, probability of diagnosis, access to healthcare, treatment adherence, and overall impact on TB communities. A national TB elimination program also recognizes existence of huge dental discrimination that exists, and it also recognizes that more women die of TB than for all reasons of maternal mortality. And I would also like to touch upon all issues, challenges, manifestations related to TB and women. Rising population, coincidence of HIV, rising poverty, drug resistance, and huge burden of disease in women. Women are increased risk of progression during the reproductive years. It is for biological mechanism. It's accepted that there are more cases amongst men. But at social, economic, and cultural level, there are a lot of barriers to healthcare as far as women are concerned. Even now, there are under notifications. And that's why we have to make our TB program entirely gender sensitive. We have brought the law, we have an act. Let's see if it is followed in letter and spirit, and how do we carry on the implementation. Of course, fear, stigma has been very profound, and there has been huge ostracization of the workplace, within the community, within the society. I've seen people even in my own neighborhood, a young 26-year-old a couple of years ago, and she was thrown out by the family, young daughter-in-law, 26-year-old, and she never returned for 10 years. I don't know what has happened to that family now. So it continues in towns, cities, not just villages and rural areas. And we also know that tuberculosis creates more often in impoverished families, and because women are the caregivers of the family. And it is on record to say that while men spend only about 36 minutes on normal household jobs, these are unpaid jobs, women spend nearly 6 hours. And driven by COVID, I'm sure where this 6 hours figure would be today, because they just virtually left to take care of everything. Even if there's one COVID patient in the family, everything falls upon the woman. She is the last one to receive attention, and she is first one to give attention to other people. So TB also has a diverse effect on child survival in many of the families. And let me tell you that there is a broad data on nearly 10% marriages have ended in divorce. 16% widows face suicidal issues. And 25% women have been isolated or disconnected within their own social groups. And 18% women have been rejected by husbands or in-laws. And tuberculosis among mothers gives 6-fold increase in prenatal death and 2-fold risk of premature death. Genital TB associated women difficult to diagnose is also one of the major important causes of infertility. I mean, TB is still one of the leading non-obstetric causes of maternal mortality. And this is all peculiar to women. And when it comes to fighting at the front, it's only women. Look at the way they conducted themselves during the recent COVID pandemic. Why recent? It's ongoing. We're still part of it. And they are the first responders to any health crisis. Our nurses, professionals, our midwives, and only between ASHA, accredited social health activists, and ANS people, they were the grassroots workers. And whether it was delivery of services, whether it was responding, at the first point of response, it was these people. They were like shining warriors. But Sadly, I must remind the government, we have also given in writing that very little attention is paid when it comes to compensating them in terms of wages, remuneration, funds, salaries, whatever. And almost we are lackadaisical in terms of even imparting training, having any organized cadres. And since India has a huge shortage of trained health workers, it is time we learn from experience. Asha has delivered so beautifully in the last 15 months. Why don't we build on these? We must build their capacities. We must take it seriously to ensure that all necessary facilities are provided. And no amount of compensation would be enough for those who stake their lives to ensure that they are the frontline warriors in this pandemic. Then, as it is, there is very little chance. We know also from the data that not more than about 16 to 17% of these so-called people from the nursing career will ever graduate to becoming allopathic doctors, because 84% of them are still men. And there is a huge gap. And because there is a huge gap, we have to look at management strategies to ensure that there is more mainstreaming for women into all of this. Thank you.
Thank you so much, Dr. Singh. And as always, thank you for your leadership to bring TB to the forefront. And we will continue to work with you, support you, learn from you. Thank you for your time today, sir. And with that, I'm actually going to now involve the audience that has been so patient and leaving questions for us to take up towards the end. There will be a poll that's coming up. Please click the link, which is given in the chat. Take 15 seconds to just vote on this question. And while you do that, our teams would be putting up the answers. And with that, we will go into the next conversation point. The question that we have posed to you today is, who do you think is most stigmatized due to TB? We've been talking about it. It is the women. And as we continue with the conversations with Ms. Blessina Kumar and also our very own Malika, who's been leading the gender work at KHPT for close to a decade, I think we will see that percentage rise. We will see, we'll understand what the key issues are and hopefully learn from today's session on how to address this, not only for women, but also the other vulnerable populations we've been talking about. Thank you, Team KHPT. With this, I will turn to Ms. Blessina Kumar, who's been waiting patiently. Thank you for joining us. I know the last 1 month has been a trial time for you, but we are so happy and glad that you're well and with us, and more strength and power to you. We'd love to hear your thoughts around the global best practices, because I think for any country to do well, it's also important to learn from examples that may have worked. So I'm going to turn this over to you, and I'm going to request Shramana to share the slides for Ms. Kumar, please.
Thank you very much, Sukriti, for those very kind words. And thank you for inviting me to speak. This is the first webinar I'm speaking after after battling COVID. So it's very special for me as well. And I want to congratulate KHPT for organizing this. I think it's the right time for us to be discussing gender and how do we respond to the TB problem, and also understand stigma. And speakers before me, especially George and Dr. Singh, have touched on some very key points. So it makes my, kind of work a little bit easier. My topic I was asked to speak on was global best practices. It was very interesting. And I think I will bluntly say we don't have any in TB. So that also provides a great opportunity for us as a country to lead in this, because I think we have what it takes to actually document best practices in this. Next slide, please. So I'm with the Global Coalition of TB Activists, which is a coalition of people affected by TB, bringing the lived experiences of our own TB journeys to the global platform towards a people-centered, rights-based response, and also try and bridge the gap so that policy can change. Next slide, please. And our focus areas are community mobilization, capacity building, advocacy at different levels, global, regional, national, and also keeping in mind that TB remains people-centered and rights-based. And one of the things that Dr. Singh very rightly pointed out is policy. And we really strive towards changing policy to be more people-centered. And we've had 2 great successes recently that I will share about. And we also focus a lot on communication. Next slide, please. So to reiterate what the other speakers have said, we cannot end TB if we don't end stigma. It's simple as that. We want to end TB, we need to look at stigma. So this is a great workshop for us to be part of. Next slide, please. So it's important then, for us to start building evidence. Because if we start just saying stigma, 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 address stigma, it may not have the same impact. So we need to build evidence starting from the ground realities of people affected by TB. What is it that they're experiencing? So I'm going to share with you the Global Coalition of TB Activists, our experience. We conducted workshops across the globe, Africa, Asia Pacific, Latin America, India, Indonesia, several workshops. And I think we would have trained nearly maybe about 400 people in all these workshops. And it was very interesting when you take them through an exercise of identifying barriers, along the cascade of care. 3 barriers were identified across the board, whether it was in Peru, in Latin America, or Indonesia, Philippines participants, India, it was the same. 3 top things were identified. One was stigma, one was lack of information, and one was lack of counseling. Very interesting. We expected them to say, no drugs not available. We expected them to say, we don't have money. But it was really interesting that when we analyzed the exercise that was done, these were the top 3. And this is what communities are saying. It just needs us to listen. Next slide, please. So we know that stigma is the biggest barrier. Listen to what people are saying. I mean, Naomi is a nurse who went through MDR treatment from Kenya. She said nobody was willing to give her injections. So she had to inject herself. Mileni from the Latin American, actually Colombia, she said she was separated from her daughter because they wouldn't allow them to be together for 3 months, a small child. And Mona from India, she lost her job. I mean, this is ridiculous because they said, the TB drugs change the way you look. And they said, you can't sit at the front desk anymore because, you don't look good anymore. Our Indian obsession with fairness. So this is what women go through, and imagine the impact it has on your own self-worth. Next slide, please. So George is very clear. Sorry, I didn't realize I was muted.
We heard you till Dr. George has clearly.
Okay, so George has very clearly highlighted the consequences of stigma. So I'm not going to dwell on that. We know that it's huge. It impacts individuals hugely. It reduces us to being something so small and affects the way our lives journey continues. Next slide, please. So then, We need to remove these barriers that communities are talking about. Many times we see that you recognize the barriers. If you see the left-hand side picture. And most programs, what we do is we do some jugaad. You know, you remove the box from the tallest child or person, and then you put one box on top of the other and lift the little fellow on top, fellow or girl or whatever, so that he or she can see the match. But that doesn't remove the barrier completely. What we want to do is the third picture on the right. You want to remove what is actually blocking the view. So now everybody has a very good view without having to balance on anything. So when we plan our programs, removing barriers, let's remember that we need to do what is in the third picture. Next slide, please. So we, tried to do this, removing barriers, step one, by documenting the experiences of women who went through stigma way back in 2018. And we had stories from across the globe. We launched this booklet at the civil society hearing at the United Nations. And you can click on it, please. And this, then everybody said, but what about children? So we documented stories of children who and their carers who had experienced stigma, and then went on and this was also launched in 2018 at the Union Conference. And the third one was the book on men, because everybody said, oh, are you saying that only women and children face a stigma? What about men? So again, it wasn't for us to say, no, transgenders feel or men feel. We said, let's get it from the people who are experiencing. I would highly recommend that you go through these books. It's very small. It's in the link on the chat. Please do read this. It's people speaking about their own experiences. So first thing we did was actually to document that. Next slide, please. Then for the lack of knowledge, we tried to develop tools to help build capacity of communities, affected communities. And one of the things, the first thing we did was the one on MDR-TB. The training modules worked with the community to come up with this. And we did this along with WHO Southeast Asia Regional Office and the Red Cross, International Federation of Red Cross, and the Stop TB Partnership. And we have conducted these trainings, and others have also used this to conduct trainings in the Southeast Asia region. Then along with partners, we developed a training module for TB, drug-sensitive TB, transforming the TB response, capacity building of communities to be change agents. We just don't want survivors to talk as survivors, but we want to see a change and actually encourage people who have gone through TB to become those change agents. And this has also been translated by our partners and is being used in Africa and in Indonesia and in South India. And then we did work with partners to do our own NTEP from TB survivor to TB champion training curriculum. And then one of the first efforts were to unpackage the guidelines that come from WHO, which are so technical that the communities cannot understand this. So we unpackaged this on TB preventive therapy, brought out a small brochure, again, along with the WHO Southeast Asia Regional Office. It answers different questions on TB preventive therapy. And we are actually doing a workshop on this for TB champions on Monday in Hindi. Next slide, please. And then we also developed a fact sheet along with USAID and Reach India, and Learning for Impact, focusing on India. Some of the examples are in that. Again, a great a tool for people to read. And the latest one that Dr. George also spoke about, that we are so proud of, is the strategy to end stigma and discrimination associated with TB. And I must congratulate and thank the National TB Elimination Program for being so open. You know, there was a time, I think a decade ago, when all these things were not considered important. You know, only treatment, only diagnosis. But now we have come such a long way that these are really seen as important components. You know, they're not at the fringes, they're not soft things anymore, but as integral to ending TB as anything else. So this is a document that again was launched by the health minister at the World TB Day event in 2021. Next slide, please. So it, you know, for policy change, you have to get the evidence from the ground realities. You have to document it. You have to make a noise. You have to advocate at the highest level. You and partners around need to keep emphasizing and re-emphasizing. And we did that. And I am so, so proud to say that all of us, all our efforts have actually resulted in stigma and human rights becoming one of the 10 top priority recommendations of the UN Secretary General's 2020 Progress Report on TB for actions needed to accelerate progress towards global TB targets. This is huge. This is really huge. And we did it as a community, as civil society. You know, we didn't, you know, have huge funding for it. There was no funding. It's just doing things that with a passion, collecting data, presenting it, making noise, re-emphasizing, talking about it, advocating, you know, at every high level meeting, talking about it, placing those things has brought about this. And so that's a good example and best practice that, you know, we can actually place proudly before everyone because we have done it together. Next slide, please. So, you know, when we were looking at global best practices, like I said, we actually don't have much. What we have is a lot of tools, you know, for stigma assessment. Countries are now going to do the stigma assessment globally. You know, they are developing stigma evidence-based action plans. Next slide, please. You can go on to the next one. And actually, when it comes to showing the results, we don't have much. A little bit on gender. You know, in TB, I think we could learn a lot from HIV in terms of best practices. You know, if we look at HIV, the interventions of care and support actually focused on vulnerable and underserved populations. There were tailor-made programs for sex workers, women who use drugs, transgenders, female partners of male persons who inject drugs, people living with HIV, prisoners, truckers, migrants. I think we need to expand our thinking a little bit more in terms of how can we do this in TB. And also in HIV, there was a lot of promotion of livelihood support, economic support for women affected by HIV and AIDS. And there was life skills programs for adolescents. And I think, you know, while we have come a long way, we could still do better in the way we design our interventions, our approaches. Next slide, please. And if we look at best practices for gender, I think, you know, it'll take some time for us to actually document this. We have tools, but we don't have that sort of end best practice, which I hope we will be able to have. Just a few examples. Global Fund has a technical brief. Stop TB Partnership has a paper on developed a paper on gender and TB, and from GCTA we held the first all women high level webinar where we had the UN Special Rapporteur on Health, WHO, USAID, Global Fund, Stop TB, Civil Society Task Force, TB survivor and researchers come and actually discuss way forward towards a gender sensitive and equitable response to end TB. Next slide, please. And India actually has a national framework for a gender responsive approach to TB in India, which other speakers also have spoken about. And there are some examples from Indonesia, Ukraine, where gender responsive programs are being planned, are being thought about, and along with the communities. And we hope that in this year, towards the end of this year, we will actually see best practices impact coming out of these efforts. Next slide, please. Again, this is some of the initiatives that Stop TB Partnership Indonesia, some of the HIV TB programs again in Indonesia are doing. But I wanted to highlight one best practice, perhaps that we can concretely say from Peru. We work quite closely with our partners in Peru, Socios and Salud, and they had a project in the women's prison. And in 9 months, they diagnosed 9 women with TB. And in this prison previously, they could only diagnose 5 per year. So you can see the difference. When we have tailor-made programs, the impact is much more. Next slide, please. So I think what is needed right now is action. We have the paradigm shift. Our paradigm has been shifted completely from a very medicalized TB response to a people-centered rights-based response. We have the tools in India. We have these amazing tools that NTEP with partners has developed. They shouldn't sit on a shelf somewhere. Then the whole purpose is lost. They have to be used. And what is needed right now is action. And I do believe that India can really show the way forward in terms of documenting the impact of our efforts in documenting the best practices for the world to actually pick up and move. Thank you very much.
Thank you, Blessy. And at the beginning, you mentioned how this is the first webinar after you've come back. So I really, really appreciate your support. And on behalf of all of us, a big thank you and take care. With that, I'm just going to request the team to, there's a 30-second video just to give all of us perspective before we move to Malika from KHPT, who's going to take a few minutes to talk to us. On a time check, we are over by 7 to 8 minutes, but I think we can pull back because there are some questions which I want to pose to the panel. Sucheta, over to you. Can you play the video?
जब से माँ को नानी के यहाँ भेजा, कितने चिड़चिड़े हो गए हो?
बेटा टीबी है उसको।
टीबी का इलाज तो यहाँ भी हो सकता है, फिर क्यों भेज दिया?
अगर वो यहाँ रहती ना, तो लोग कन्नी काट रहे होते हमसे।
मुझे लोग नहीं, मम्मी।
अरे क्या? अर्जुन उठेगा तो सरप्राइज देंगे। हाँ?
अर्जुन
बहुत मिस कर रहा था तुमको, और मैं भी टीवी रिमोट का सर पर समझ नहीं पा रहा था। अपनों का जोड़ है टीबी का तोड़, तो फिर भेदभाव क्यों? टीबी के इलाज में अपनों का साथ दें।
Thank you so much, Sucheta. Malika, bringing you in, and Blessina touched upon inclusion, passion, and I think that defines a lot of the work KHPT has done over the last 2 decades. I'm going to turn this over to you. You're the expert here, and welcome to the conversation.
Thank you, Sukriti. And no, I'm not an expert. We're all learning. And I think we've had some really esteemed panelists go before and set a very strong foundation for this workshop. So thank you so much for that. I consider it a great privilege to be able to really speak on the same platform. So thank you. So good morning, everybody, to all our attendees, our esteemed panelists, and of course, all the ones who are working behind the scenes really hard, and people from the KHPT team who've really shaped what I'm going to be sharing with you all over these years. In KHPT, our experience of working with communities and the health system infrastructure for almost 17 years now, across themes like MNCH, TB, HIV, adolescent health. The one thing that we found is that focusing on gender-specific vulnerabilities in a very targeted fashion can really accelerate every program towards its goals. And therefore, what's connected to this as a deep understanding of how gender norms and gender-related vulnerabilities manifest, across all contexts, within families, within community groups, as well as service delivery platforms, is absolutely critical to be able to really make a dent and to really see gender integration in the true sense of its word. Before I move on to what we did, and I know we're running short of time, so I'm going to keep this really crisp. I thought it would be valuable to share a few scenarios, and I really benefited from Blessina's conversation and the experiences and the stories she shared and as part of her talk. I want to share a few scenarios, and these are scenarios that refer to particular community members that we worked with over the years, but we've seen these scenarios repeat itself, not just in the context of TB, but in the context of the other diseases and disease control initiatives that we've been a part of as an organization. So scenario one, this is Lakshmi. Lakshmi is aged 35, and she was the first to contract TB disease in her family, following which her husband and her in-laws become TB positive. And even years later, after they're all cured and doing fine and back to life and routine, the family still blames her to be the cause of infection and holds her responsible for it. Scenario two, Saida is a newly married and a pregnant woman with a child. She contracts TB after caring for her TB positive husband. Saida is given no option but to return to her parents' home with the baby she's carrying and leaving the older one behind at her husband's until the time that she would be called back. Saida leaves, and she's never been called back to her home, and she's never been able to, go back to her older child and never seen the child ever since. Scenario three, Pavitra is 18 years old. She's asked to give up college to care for her TB positive father and grandfather, while her 20-year-old brother is forced to go to class despite his wishes. She agrees with a heavy heart. After all, every woman is the default caregiver, even if she has to pay heavy costs for it. Scenario four, Esther is a health worker in Bangalore urban slums, working for a TB program, and she's the sole earning member of her family. She looks after her ailing husband, she educates her 2 children, and she attends to household chores. Despite this, a slap or 2 at home because of overstepping her boundaries as a wife is common. But Esther says, at least he lets me work. I can bear a slap or 2 once in a way. Scenario 5. Pallavi is a supervisor. She has about 15 community health workers working under her, of which 7 or 8 are men. Some of her subordinates who are male do not think that they need to report to her and would rather contact their male lead in the office. Pallavi's advice and suggestions are not heeded to, and her views are grossly and publicly disrespected. So these are not fiction stories, and these are real scenarios. And I know that there are many people here on this call who've been closely involved in work at the grassroots. And I'm sure they will agree with me that they keep seeing this time and again in their work with communities. What does this really point to? This points to the fact that perceptions on who women should be, when I say women, please do note that I also refer to people across gender identities, how much value should be or can be ascribed to them, and what boundaries within which they should work is determined by certain that are in positions of power. So in our experience, one thing that we've internalized and one thing that we've reflected upon as a KHPT team, as an organization, is that if we were to integrate gender into programs, it has to stem from a very clear understanding of how really power plays out, and in ensuring that we become facilitators of a process that transfers power from those that hold it to those that are deprived of it, right? So how did we tackle this as an organization? Across all our projects, including the one that we're implementing right now on TB, the first thing I would just like to highlight 4 or 5 approaches or 4 or 5 specific things that we do, and we hope that it will be useful for those that are already doing this or maybe enhance it as part of their effort on the ground. So the first thing is change norms. I think we have a critical responsibility to challenge social and gender norms, and we have to start with one individual, one family, and a community at a time. I'll give you a very small example. You know, we have an adolescent health project that we implement in Northern Karnataka, specifically with the objective of enhancing health and well-being of adolescent girls from vulnerable households. And I still remember that we are working towards building role models among the adolescent girls, and we speak a lot about gender and empowerment and power, self-esteem, confidence, etc. And I remember one of the girls after that meeting, she just goes back to class and she sits with a girl who's from a lower caste. In her class, it has been a tradition that some girls, about 3 of them who come from a different caste, who come from a lower caste, sit on the last bench and nobody else sits with them. So this girl took that opportunity to put what she's learned into practice and said, from this day, I'm going to sit with these girls on the last bench. What was she doing? She took a teeny weeny step to change a norm. And following suit were many more girls who started breaking that barrier. And suddenly what was a norm, what was accepted, what was not spoken of, what was underlying in that village began to change. And that is how we change norms. And we have to create space for that. We have to trigger that as people who are working with communities. And that's really critical. Employing transgenders into leadership roles. Ensuring that a husband is portrayed as a caregiver for an unwell wife. In many families, that doesn't happen. So these are tiny things that we do to change norms, to challenge social and gender norms that are counterproductive, that are not going to help us sort of realize our goal of gender equity. The second thing that we did, we all speak about empowerment, but in our organization, we've done a lot of work and thinking and even sort of undertaking research studies to really define empowerment. What do we mean by empowerment? And I think we feel very strongly that this definition should be derived by those who wish to be empowered. And I think we have to be people who will allow for the communities to shape the discourse around empowerment. Allow for female TB patients and caregivers to define what empowerment means to them, and not we sort of deciding that this is what empowerment should be or look like. And that may vary from community to community, but are we creating space for that? Are we looking at the micro before we get into the macro? So that's critical. The third aspect is creating safe spaces to collectivize. You know, in one of my conversations with a frontline health worker, she said, "Madam, it's so easy to get women to come for this meeting. It is so easy for getting them to change their behaviors because they just want to get better as soon as they can so they can continue playing the caregiver's role that everybody else expects of them and feel good about themselves, that they're doing what they ought to be doing." So one thing we realized is that space for women to collectivize, the space for women to share openly and fearlessly in an environment that respects confidentiality and privacy is critical, because women just don't have a go-to place to talk about what their challenges are. So safe spaces helps collectivize. And when you collectivize, there's collective power. And when you have collective power, you're able to shape discourse like Blessina was sharing. The fourth thing that we strongly believe in is to work with families. We have an approach called family-focused communication. We undertook this in our work with pregnant women, in our work with adolescent girls, in our work also now with TB patients, is don't leave the family outside of your interactions, whether you want to change behaviors, whether you want to, sort of drive messages around treatment and care, or you want to talk about gender, include the family. So what we call FFC in KHPT, family-focused communication. Recognize and acknowledge the role that all members of the family play in creating an enabling environment for the woman or for any other person that needs support. Fifthly, position the issue of gender as a cross-cutting theme, and therefore We have to create scope for those who are discriminated against to be at the forefront of the change process. So when we are having discourses, deliberations like this, we need people who have actually been through the experience to be at the forefront of these conversations, telling us, giving us direction as to how things can change. So that's very, very important. My sixth point is on empowering the frontline. We feel this is extremely critical because we also feel that the very frontline workers who form our critical link between the community and the health systems themselves are disempowered, themselves are battling challenges with no redressal mechanism, with no support systems. So how are you really ensuring that our frontline is empowered to tackle or to take on discrimination head on, in their daily interactions on the ground? So that when you do that, you actually promote a lot of collaborative action amongst frontline health workers. That's really, really critical. And lastly, I think Blessina did touch upon it, is about financial inclusion. We also believe that financial inclusion is a critical aspect of gender integration within any sort of public health program, so to say. So these are some quick inputs that I'd like to leave the team with. And at KHPT, we have ensured that our tools, our modules, our trainings, communication strategies, all of them are developed to be gender transformative. And literally the focus on vulnerable communities from a gender lens runs within the DNA of our organization. And within our own teams, whether it's staff that's working at the central level or at the field level, we try to see how this perspective can be built and this culture of equity can be propagated across all levels. And I think that is really critical because really change starts at home, right? So this micro to macro perspective is really important. I'm so happy that a lot of people here who spoke from stories, spoke from real issues that people see on the ground. So I'll just end with a small incident that I will actually not forget for a very, very long time. As part of our work with MNCH, we implemented a training, a perspective building training for frontline health workers. And in the history of work on MNCH in Karnataka, this was the first training that had brought Anganwadi workers, ANMs who are now called JHAs, and the ASHA workers under the same platform. It had never happened in the past in the districts that we were working with. And as a result of the 3 days of interactions and deliberations, speaking about gender, I remember this one thing that the Anganwadi worker told us. She said, I used to think that I was a health worker and I took pride in the department that I represented. My role was limited by the role of a health worker and by the role that a health worker is expected to play. But after being trained, after listening and sitting in the same roof with women like me, I take pride in the fact that I'm a woman first, no matter which department I represent. And now that is going to steer my effort in the way that I deal with the other women that I'm working with. So I'm first a woman and I understand the issues of women better than anybody else. And I'm now willing to work with an ASHA worker. I'm now willing to work with an Anganwadi worker because we come together because we have the same stories to say. So this is something that was an eye-opener for us, as an organization, and it really benefited us. It steers us to sort of look at this issue from that lens. And I'm going to end here. So thank you so much once again for giving me the opportunity. I know that the state teams have, experiences to share, which of course will be very, very valuable. So Sukriti, thank you so much for giving me this opportunity. Thank you.
Thank you, Malika. And I know we are at 12:42, so I'm going to turn to Mamta to take about 20 minutes to take us through the case studies. And if I can request the audience for just 5 extra minutes, there are some very interesting questions which I want to pose, but that will depend on the time. So Mamta, over to you, and please guide us through the next session.
Thank you, Sukriti. I am Mamta, leading this project. I just wanted to brief about Breaking the Barriers project. And the objective of this project is to develop and scale up effective behavior change models among urban vulnerable groups, tribal groups, migrant population, and mining and industrial workers, and also tea garden workers. And this is to increase the case notification, also to improve the successful treatment outcomes among TB patients. And we have been implementing this project in 15 districts across 4 states, Karnataka, Telangana, Bihar, and Assam. And we have STOs from these states. We are also, in this project, we are leveraging on the socio-ecological approach. It's a framework. And we recognize, as all the eminent speakers shared, the structural and the underlying barriers that exist among vulnerable population. The main important barrier being gender and stigma. So from this, I just wanted to move on to sharing, like allowing all the 4 states STOs have been waiting to share their experiences. I just want to brief and then invite them. Throughout the TB journey, we have, like all the eminent speakers shared, the community has been experiencing hopelessness, sometimes shame, and we also have seen broken relationship, and many of them have lost their jobs, all as a result of this TB stigma. And I just also wanted to add, some of our TB patients also have stopped their treatment because of lack of care, counseling, social support, and economic financial assistance. So I want to share one personal experience. When I visited Ballari recently in the month of January, one woman shared her treatment journey. And because of the stigma associated with TB, she and her family did not reveal the illness, which made it very hard to seek the treatment. Probably the self-stigma is very, very strong, and she wanted to give up and quit the fight. Our field team then actually intervened, counseled, facilitated to instill the confidence and esteem in her, self-esteem in her. I now call upon, invite all the STOs across all 4 states. I would like to invite Dr. N.J. Das, who is the State Tuberculosis Officer from Assam. Over to you, sir.
Good afternoon. Good afternoon.
Yes, sir. You're audible.
Yeah, good afternoon. I'm coming near the mic and camera. So, welcome everybody. Am I audible?
Yes, sir. You're audible.
Actually, it is very difficult to speak in front of such a galaxy of good orators. All are good orators, with good smile, with lots of seriousness, like Dr. does, looking very serious about the issue. Of course, Singh Sahib is also there. So, what shall I have to take, Mamta? What would you like to hear from the Assam perspective?
Sir, could you please share some of the impact stories from the field with respect to gender and stigma, your experiences in the field, sir?
Thank you. Actually, by being an inhabitant of Assam, I give less importance on gender discrimination or whatever you like, because we do not discriminate between male and female, female and transgender and male. We do not have any discrimination as such. There may be one or two persons who can practice that, but at large, we are all equal. We think like that. So there is least amount of discrimination among ourselves in the society. But first, we are Indian, so we have to have certain discrimination also. So if we go by statistics, 67% of the males notified are males, TB notified are males, 33 are female, 1 are transgender. 1 transgender because there is less prevalence of transgender in this part of India. Males are more predominantly notified in number than the female because there are certain things like stigma, as discussed all over for the session. marriage, divorce, delaying care-seeking behavior. They have to get permission from the household or the head of the household, and need to support. They can need to take support from the home, anyone for going out to seek the benefit. They have to depend financially, the female. Then they cannot take they means the female cannot take their decision out of their own. All these factors lead them for poor notification as per number. On the other hand, there is a group of TB notified cases which are called clinically notified. In clinically notified, you may have to come across certain investigations and all, which may buy time, which is well afforded by female because they have plenty of time. But males cannot afford to time because they are the breadwinner, they have to go for work. All these things. So, clinically diagnosed TBs are about 50% are male, whereas 70% are transgender and 56% are about 56% are female. This is as per statistics. This is because this change is because of unwillingness to spare time for the entire period of diagnosis, time of diagnosis, and stigma related to attend diagnostic centers and all. Outcome, females have a better outcome, though marginal, than the male, because female knows the responsibility of taking the drug, because she has to take the drug. It may not be necessary for her only, it is necessary for their children, for their husband and the whole household. So they take care of themselves for the sake of others. This responsibility always lies with the female. That is the sense prevailing in the society. Whereas the male, they do not have to think, they never think in this line, so their success rate is a bit less, low margin. And if you go by a case study regarding a TB champion, which is infested by tea gardens. So wherever there is more areas of tea garden infested area, then there will be lots of tea garden workers also. They are supposed to be there. And usually the tea garden workers in Assam are Adivasis, but they are part and parcel of the Assamese society because more than 200 years they are here.
We have a limitation on the time, sir. So if you could complete before another 1 minute, that would be great, sir.
So there was a lady who was suffering from TB, and she took the drug very meticulously. And during the course of treatment, we were observing her that she was very meticulous and sincere about taking the drug and sincere about propagating the matter, the sense to the other part of the community, so that they could prevent others to develop TB. We identified that person and made her TB champion. Then after giving proper training, she started working as TB champion, and we prepared some hoodies and other things so that it can be displayed in the society to educate others. By that way, we are very happy. She was also very happy. But another side of the coin was also not very happy. So she had to look after her husband. She had to look after her children. Everything got mingled up, and that created some disadvantage in working as a TV champion. So my suggestion will be, if we can bring in the household of that particular TV champion and put them in the program with the TV champion designated as the lead, then if the whole household works for the TV, then that will be very beneficial for the program. That I can say.
Yeah. Thank you, sir. Thanks for your suggestions, and also you have brought in the actual facts from the field. Thank you very much, sir, for sharing in the larger group, and it's going to go a long way during the implementation of the project, sir. Thank you, sir. I now request Shri B.K. Mishra, Dr. B.K. Mishra from Bihar, State Tuberculosis Officer from Bihar. Over to you, sir.
इसको करिए तो ठीक से. Let me first thank you for giving us opportunity, and it was quite a learning experience for all of us. Personally, I believe that we have not done anything very much in the TV to make it more gender sensitive. But today I have taken few lessons from the very knowledgeable speakers, and what comes into my mind, that wherever the women are TB patients, they are diagnosed, so there is a delay in coming to the health facility for consultation. So we will find out and we will work it. How can we minimize the delay in seeking the health care? And right now, being a apolitical person, I should not comment politically, but I cannot resist admiring my Honorable Chief Minister, present CM, Sri Nitish Kumar ji, for making the 50% reservation across the state in Panchayati Raj system, and we are seeing the fruits of that reservation. Second thing, that 35%, there is a 35% reservation across the state in all category of the government jobs. And you must have seen the newspaper that now 1/3 of the seats in the medical colleges and engineering college, also that alcohol is banned in our state. It is a very contentious issue because of the economic plight of the state. But still my government understands that prohibiting the alcohol in state has encouraged the women, including the TB patients also, I will say, because the alcohol as such is very difficult to get. And so I cannot resist admiring a very small NGO, Daniel Foundation India Trust, that works in 6 or 7 districts in the North Bihar, Madhepura, Saharsa, Supol, Sitamarhi, Darbhanga, Madhubani and Samastipur. So what they have done, that anyone, whether it is a man or woman, if man, particularly the bread earning person of the family who has died due to tuberculosis, they financially rehabilitate. And when they say, they don't saw the data, most of the time it was the women who were, actually the women are not suffering only due to their tuberculosis, but if a husband dies, or if being our state is very much we are ashamed of having the migrant population. So due to the corona or anything, so the migrant population, and whenever they are become sick in the south or the Punjab or anywhere, they come with the TB and also with the HIV or the drug resistant TB and everything. Now the soul, the person who was earning has now become the burden in the family, and who has to take the burden? It is the woman of the family. So we understand the pain, and as a state TB officer, I have done nothing for the TB patients, particularly the women. But we have started one thing with the help of our Honorable Deputy CM, Madam Renu Devi. So what we have done, that the TB survivors in the 19 districts, particularly the women, they have been trained and they are engaged as a counselor in the through the teleconsultation or anything to the women to take that care. So, and it has given us this in the COVID, during this second surge of COVID-19, that through them we are tracking the patient whether they are getting the medicine or not, and it has given us the very supportive role. So we want to escalate it and implement across the state in all the districts with the help of this KHPTC. Thank you very much, madam. I will not take much time.
Thank you very much, sir. I just wanted to say you have highlighted on going forward, you would like to implement, take this stigma and gender as a very rigorous point in your approach. Thank you very much, sir, for bringing that point. And I now invite, I just wanted to say Dr. Ramesh Chandra Reddy is the STO of Karnataka, State Tuberculosis Officer of Karnataka, and he's not able to make it. On his behalf, we have drug-resistant TB coordinator, NTP from Belagavi District, Karnataka State, Raman Gowda Patil and Parashuram Patil. So I over to Parashuram Patil and also Raman Gowda Patil. Over to you.
Namaste, ma'am. मैम लोकल लैंग्वेज में बात कर सकते हैं?
Yes, yes, yes.
तो कन्नड़ में मैं बताना चाहूंगा.
Yeah.
Okay, okay. ನಾನು ಪರಶುರಾಮ್ ರಾಮಚಂದ್ರ ಪಾಟೀಲ್, DRTB ಕೋಆರ್ಡಿನೇಟರ್, ಬೆಳಗಾವಿ ಜಿಲ್ಲೆ. ಸೊ ನಾವು ಒಂದು ಜೆಂಡರ್ ಡಿಸ್ಕ್ರಿಮಿನೇಷನ್ ಸಂಬಂಧಪಟ್ಟಂಗೆ ಒಂದು ಪೇಷಂಟ್ ಸ್ಟೋರಿ ಬಗ್ಗೆ ಇಲ್ಲಿ ಹೇಳ್ತಾ ಇದ್ದೀವಿ. ಸೊ ಪೇಷಂಟ್ ಹೆಸರು ಕೂಡ ಚೇಂಜ್ ಮಾಡಿದ್ದೀವಿ, ರಾಮೇಶ್ವರಿ ಅಂತ ಹೇಳಿ. ಸಿ ಇಸ್ ಅ 36-year-old ವುಮನ್. ಇವ್ರಿಗೆ ಮದುವೆ ಮಾಡಿ ಇಚಲಕರಂಜಿ ಮಹಾರಾಷ್ಟ್ರಕ್ಕೆ ಕೊಡಲಾಯಿತು.
Go ahead.
Okay. 36-year-old woman. First time ಇವರು TB ಡಯಾಗ್ನೋಸ್ ಆಗಿದ್ದು August 2020 ಇನ್ ಇಚಲಕರಂಜಿ. ಸೊ ಇಚಲಕರಂಜಿಯಲ್ಲಿ ಇವರು ಡಯಾಗ್ನೋಸ್ ಆದಾಗ ಇವ್ರ ತೂಕ 32 kg ಇತ್ತು, 33 kg ಇತ್ತು. ಬಟ್ ಕೌಟುಂಬಿಕ ಸಮಸ್ಯೆಯಿಂದಾಗಿ ಅವರು ಬೆಳಗಾವಿಗೆ ಟ್ರಾನ್ಸ್ಫರ್ ಆದರು. She came Belgaum in the month of October 2020. When she reached here, her weight is 28 kg. ಸೊ ನಾವು ಕುಟುಂಬದ ಸದಸ್ಯರಿಗೆ ಕೇಳಿದ್ವಿ ಯಾಕೆ ಹೀಗೆ ಇವ್ರ ವೇಟ್ ಲಾಸ್ ಆಗ್ತಾ ಇದೆ ಅಂತ ಹೇಳಿ. ಅವ್ರು ಹೇಳಿದ್ರು ಇಲ್ಲ, ಕೌಟುಂಬಿಕ ಸಮಸ್ಯೆಯಿಂದಾಗಿ ಇವಳ ಪರಿಸ್ಥಿತಿ ಹೀಗಾಗಿದೆ, ಇನ್ನು ಅಲ್ಲೇ ಬಿಟ್ರೆ ಇವಳು ಸಾವನ್ನಪ್ತಾಳೆ ಅನ್ಕೊಂಡು ನಾವ್ ಇವ್ರನ್ನ ಬೆಳಗಾವಿಗೆ ಕರ್ಕೊಂಡ್ ಬಂದ್ವಿ ಅಂತ ಹೇಳಿ. ಸೊ ನಾವು ಮೋಟಿವೇಟ್ ಮಾಡಕ್ ಪ್ರಯತ್ನ ಮಾಡಿದ್ವಿ, ಪೇಷಂಟ್ಗೆ ಹಿಸ್ಟ್ರಿ ಎಲ್ಲ ಕೇಳ್ಕೊಂಡ್ವಿ. ಅವಾಗ ಅವ್ರ ಕುಟುಂಬ ಸದಸ್ಯರು ಹೇಳಿದ್ರು ಇಲ್ಲ, ಇವ್ರ ಪತಿಯವರು ಗಂಡು ಮಗುವನ್ನು ಬಯಸ್ತಾ ಇದ್ರು, ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಇವ್ರಿಗೆ ಮೊದಲೇ ಮಗು ಹೆಣ್ಣು ಮಗುವಾಗಿ ಜನಿಸ್ತು. ಇದರಿಂದಾಗಿ ಇವ್ರನ್ನ ಸ್ವಲ್ಪ ತಾರತಮ್ಯ ಮಾಡ್ಲಿಕ್ಕೆ ಅವ್ರು ಶುರು ಮಾಡಿದ್ರು. ಆದ್ರೂ ನಾವೆಲ್ಲ ಕುಟುಂಬ ಸದಸ್ಯರು ಕೂಡಿಸಿ ಮನೆಯವ್ರನ್ನೆಲ್ಲ ಒಪ್ಪಿಸಿ ಅವಳನ್ನ ಅಲ್ಲೇ ಕಂಟಿನ್ಯೂ ಮಾಡಿದ್ವಿ. ಇವಳ ದುರ್ದೈವಕ್ಕೆ ಎರಡನೇ ಮಗು ಕೂಡ ಹೆಣ್ಣು ಮಗುವಾಗಿ ಜನಿಸ್ತು. ಯಾವಾಗ ಎರಡನೇ ಮಗು ಹೆಣ್ಣು ಮಗುವಾಗಿ ಜನಿಸ್ತೋ ಅವಾಗ ಅವ್ರ ಪತಿಯವ್ರು ಏನ್ ಮಾಡ್ಲಿಕ್ಕೆ ಶುರು ಮಾಡಿದ್ರು, ಮದ್ಯಪಾನ ಮಾಡ್ಕೊಂತ ಇವ್ರನ್ನ ಸಂಪೂರ್ಣವಾಗಿ ನೆಗ್ಲೆಕ್ಟ್ ಮಾಡಿದ್ರು. ಇದರ ಪರಿಣಾಮವಾಗಿ ಅವಳು ಲವ್ಲಿಹುಡ್ ಕೂಡ ಸಾಕಷ್ಟು ಸಫರ್ ಮಾಡ್ಬೇಕಾದಂತ ಪರಿಸ್ಥಿತಿ ಬಂದವರಿಗೆ. ಇದರಿಂದಾಗಿ ಅವರು ಹೆಂಗಾದ್ರು ಟೇಲರಿಂಗ್ ಕಲ್ತಿದ್ರು, ಟೇಲರಿಂಗ್ ಮಾಡ್ಕೊಂತ ತನ್ನ ಎರಡೂ ಮಕ್ಕಳನ್ನ ಬೆಳೆಸುವ ಜವಾಬ್ದಾರಿಯನ್ನು ತಗೊಂಡ್ರು, ಬೆಳೆಸ್ಕೊಂತ ಬಂದ್ರು. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಅಷ್ಟೊಳಗೆ ಅವ್ರಿಗೆ ಮೂರನೇ ಮಗು ಕೂಡ ಆಯ್ತು, ಗಂಡು ಮಗು ಆಯ್ತು. ಆದ್ರೂ ಕೂಡ ಅವ್ರ ಪತಿ ಆಲ್ರೆಡಿ ಮದ್ಯಪಾನ ಕಟ್ಕೊಂಡಿರೋದ್ರಿಂದ ಇವ್ರ ಕುಟುಂಬದ ಬಗ್ಗೆ ಹೊಟ್ಟೆ ಲಕ್ಷ ಕೊಡದಂತ ಪರಿಸ್ಥಿತಿ ಬಂದವರಿಗೆ. ಕೊನೆಗಾಗಿ ಅನಿವಾರ್ಯವಾಗಿ ಮಕ್ಕಳ ಪಾಲನೆಗಾಗಿ ಅವರು ಗಾರ್ಮೆಂಟ್ ಫ್ಯಾಕ್ಟರಿ ಸೇರ್ಕೊಂಡ್ರು. ಯಾಕಂದ್ರೆ ನಿಮ್ಗೆಲ್ಲ ಗೊತ್ತಿರುವ ಹಂಗೆ ಇಚಲಕರಂಜಿ ಇಸ್ ವೆಲ್ ಎಸ್ಟಾಬ್ಲಿಷ್ಡ್ ಗಾರ್ಮೆಂಟ್ ಇಂಡಸ್ಟ್ರಿ. ಸೊ ಅಲ್ಲಿ 4-5 ವರ್ಷ ಅವರು ಕೆಲಸ ಮಾಡಿದ್ರು. ಬಟ್ ಡ್ಯೂ ಟು ಕೋವಿಡ್ ಮಾರ್ಚ್ ದಿಂದ ಅವ್ರಿಗೆ ಕೆಲಸನೇ ಇಲ್ದಂಗಾಯ್ತು. ಮಾರ್ಚ್ 2020 ಇಂದ ಅವ್ರಿಗೆ ಕೆಲಸ ಇಲ್ದಂಗಾಯ್ತು. ತಮ್ಮ ಮಕ್ಕಳ ಜೀವನ ನಡೆಸೋದು ಕೂಡ ಕಠಿಣ ಆಯ್ತು. ಜೊತೆಗೆ ಈ ಅವಧಿಯಲ್ಲಿ ಅವ್ರಿಗೆ ಗುರ್ತಾಯ್ತು ಇವ್ರ ಗಂಡ ಇನ್ನೊಬ್ಬರ ಸಂಘ ಕೂಡ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ, ಇನ್ನೊಬ್ಬ ಸ್ತ್ರೀಯರ ಜೊತೆ ಕೂಡ ಸಂಬಂಧವನ್ನು ಇಟ್ಕೊಂಡಿದ್ದಾರೆ. ಇದರಿಂದ ಸಂಪೂರ್ಣವಾಗಿ ನಿಷ್ಕ್ರಿಯಗೊಂಡಂತ ಇವಳು ತನ್ನ ಆರೋಗ್ಯದ ಬಗ್ಗೆ ನಿಷ್ಕಾಳಜಿ ವಹಿಸೋದನ್ನ ಬಿಟ್ಬಿಟ್ಳು, ತಿನ್ನೋದನ್ನ ಬಿಟ್ಬಿಟ್ಳು, ಉಣ್ಣೋದನ್ನ ಬಿಟ್ಬಿಟ್ಳು. ಇದರ ಪರಿಣಾಮವಾಗಿ ಆಗಸ್ಟ್ 2020 ಇವರು ಟಿಬಿ ರೋಗಿಯಾಗಿ ಕೂಡ ಕನ್ಫರ್ಮ್ ಆದ್ರು ವಿತ್ MDR TB. ಯಾವಾಗ MDR TB ಇದೆ ಅನ್ನೋದು ಇವ್ರು ಗುರ್ತಾತೋ ಇವ್ರನ್ನ ಅಲ್ಲಿಂದ ಹೊರಗೆ ಹಾಕುವಂತ ಪರಿಸ್ಥಿತಿ ಬಂದಿತ್ತು. ಇನ್ನು ಅಲ್ಲೇ ಬಿಟ್ರೆ ಇವಳು ಸಾಯ್ತಾಳ ಅಂತ ಮನಗಂಡಿರ್ತಕ್ಕಂತ ಕುಟುಂಬದ ಸದಸ್ಯರು, ತಂದೆ ತಾಯಿ ಅವರನ್ನ ಹೋಗಿ ಮಹಾರಾಷ್ಟ್ರಕ್ಕೆ ಹೋಗಿ ಕರ್ಕೊಂಡ್ ಬಂದಾಗ ಇಲ್ಲಿ ವೇಟ್ ಈಸ್ 28 kg. ಸೊ ಚಿಕಿತ್ಸೆ ಪ್ರಾರಂಭಿಸುವಂತ ಸಂದರ್ಭದಲ್ಲಿ 32 kg ಇರ್ತಕ್ಕಂತ ಪೇಷಂಟ್ ವಿದಿನ್ ಅ ಮಂತ್ ಸಿ ಲಾಸ್ಟ್ 4 kg ವೇಟ್ ಅಂಡ್ ಸಿ ಬಿಕೇಮ್ 28 kg. ಸೊ ಹಿಂಗಾಗಿ ನಾವು ರೆಜಿಮೆನ್ ಕೂಡ ಚೇಂಜ್ ಮಾಡ್ಬೇಕಾಯ್ತು. ಏನ್ 30 to 45 kg ವೇಟ್ ಬ್ಯಾಂಡ್ ನಲ್ಲಿ ಇದ್ಳು ಅದನ್ನ 16 to 29 kg ಇಳಿಸಿದ್ವಿ. ಅವರಿಗೆ ರಿಕ್ವೆಸ್ಟ್ ಮಾಡಿದೀವಿ ಇವಳನ್ನ ಅಡ್ಮಿಟ್ ಮಾಡೋಣ DRTB ಸೆಂಟರ್ ನಲ್ಲಿ ಅಂತ ಹೇಳಿ. ಬಟ್ ಸಿ ಇಸ್ ನಾಟ್ ರೆಡಿ. ಅವಳು ಒಪ್ಲಿಕ್ಕೆ ತಯಾರಾಗ್ಲಿಲ್ಲ. ಇನ್ ಏನ್ ಮಾಡುದು ಅಂತ ನಮ್ DTO ಅವ್ರಿಗೆ ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡಿದ್ವಿ. DTO ಅವ್ರು ಅಂದ್ರು ಚಿಂತೆ ಮಾಡ್ಬೇಡಿ, ಅವಳು ಎಲ್ಲಿ ಇರ್ತಾಳು ಅಂತ ಕೇಳ್ಕೊಂಡ್ರು. ಸೊ ಸಿ ಇಸ್ ಬಿಲಾಂಗ್ಸ್ ಟು ಬೆಳಗಾಂ ಸಿಟಿ ಅರ್ಬನ್ ಏರಿಯಾ ಇನ್ ವಡಗಾಂವ್ PHC ಏರಿಯಾ. ಸೊ ನಾವು ವಡಗಾಂವ್ PHC ಇರ್ತಕ್ಕಂತ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡಿದ್ವಿ. ಸರ್ ಹಿಂಗಿಂಗ್ ಪೇಷಂಟ್ ಇದೆ, ಸಿ ಇಸ್ ಮೆಂಟಲಿ ಡಿಸ್ಟರ್ಬ್ಡ್, ಸಾಕಷ್ಟು ಕೌಟುಂಬಿಕ ಸಮಸ್ಯೆಯಿಂದ ಬಳಲ್ತಾ ಇದ್ದಾಳೆ, ದಯವಿಟ್ಟು ಅವಳನ್ನ ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡ್ತಾ ಇದೀವಿ ನಿಮಗೆ, ಕೇರ್ ಮಾಡಿ ಅಂತ ಹೇಳಿ. ಸೊ ಅವ್ರು ಏನ್ ಮಾಡಿದ್ರು, ಇಲ್ಲೇ ಅವರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತಕ್ಕಂಥ ಒಂದು ವ್ಯವಸ್ಥೆ ಏನ್ ಮಾಡಿದ್ರು. ಸಾಕಷ್ಟು ನಿಷ್ಕ್ರಿಯಗೊಂಡಿರೋದ್ರಿಂದ ಅವ್ರಿಗೆ ಸಲೈನು ಅದು ಎಲ್ಲ ಹಚ್ಕೊಂತ ನಾವು ಅವ್ರ ವೇಟ್ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡಿದ್ವಿ. ಸೊ ಫಸ್ಟ್ ಮಂತ್ ಮುಗಿತು, ಸೆಕೆಂಡ್ ಮಂತ್ ಮುಗಿತು, ಥರ್ಡ್ ಮಂತ್ ಮುಗಿತು. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಅವಳ ವೇಟ್ ನಲ್ಲಿ ನಮಗೇನು ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಕಂಡು ಬರಲಿಲ್ಲ. ಹರ್ ವೇಟ್ ಇಸ್ ಫ್ಲಕ್ಚುಯೇಟೆಡ್ ಬಿಟ್ವೀನ್ 28 to 30 kg. ಸೊ 4ನೇ ತಿಂಗಳು ಕೂಡ ಬಂತು. 4th month follow up is positive. First month, second month, third month follow ups are negative, but unfortunately 4th month follow up is positive. ಸೊ ಇಮಿಡಿಯೇಟ್ಲಿ ನಾವು 1 month ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನು ಎಕ್ಸ್ಟೆಂಡ್ ಮಾಡಿದ್ವಿ. ಆಮೇಲೆ 5th month ಮುಗಿತು, 5th month ಫಾಲೋ ಅಪ್ ಕೂಡ ನೆಗೆಟಿವ್ ಬಂತು. 3rd month ನಾವು ಕಲ್ಚರ್ ಕಳಿಸಿದ್ವಿ ಅವ್ರ ಸ್ಯಾಂಪಲ್, 3rd month ಕಲ್ಚರ್ ರಿಪೋರ್ಟ್ ಕೂಡ ನೆಗೆಟಿವ್ ಬಂತು. ಸೊ ವಿ ಹ್ಯಾವ್ ಶಿಫ್ಟೆಡ್ ಟು ಹರ್ CP ಟ್ರೀಟ್ಮೆಂಟ್. CP ಟ್ರೀಟ್ಮೆಂಟ್ ಶಿಫ್ಟ್ ಆದ ತಕ್ಷಣ ಇವ್ರಿಗೆ ಏನ್ ಮಾಡಿದ್ವಿ, ಡಿಸೆಂಬರ್ ಮಂತ್ ನಲ್ಲಿ ನಮ್ಮಲ್ಲಿ BTB ಪ್ರಾಜೆಕ್ಟ್ ಸ್ಟಾರ್ಟ್ ಆಯ್ತು. ಸೊ ಈ BTB ಪ್ರಾಜೆಕ್ಟ್ ಕೂಡ ಇವ್ರು ಲಿಂಕ್ ಮಾಡಿದ್ವಿ. ಡ್ಯೂ ಟು ದಟ್ ರೀಸನ್ ದೇ ಕೇಮ್ ಟು ಕಾಂಟ್ಯಾಕ್ಟ್ ವಿತ್ ಮೆನಿ ಪಲ್ಮರಿ TB ಪೇಷಂಟ್ಸ್. ಸೊ ಯಾವಾಗ ಇನ್ನಿತರ ರೋಗಿಗಳಿಗೆ ಜೊತೆ ಇವರು ಕಾಂಟ್ಯಾಕ್ಟ್ ಬಂದ್ರು, ಇವ್ರ ಮನಸ್ಸಿನಲ್ಲೂ ಕೂಡ ನಾನು ಬದುಕಬೇಕು ಅನ್ನುವಂತ ಛಲ ಬರ್ಲಿಕ್ಕೆ ಶುರು ಮಾಡಿತು. ಇದ್ರ ಪರಿಣಾಮವಾಗಿ ಇವತ್ತಿಗೆ ಅಂದ್ರೆ ಈ June 20th ಹರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ವಿಲ್ ಬಿ ಕಂಪ್ಲೀಟೆಡ್. June 20th ಅವ್ರ ಟ್ರೀಟ್ಮೆಂಟ್ ಮುಗಿತಾ ಇದೆ. ಸೊ ಈ ಅವಧಿಯೊಳಗೆ ಅವರ ವೇಟ್ ನಲ್ಲಿ ಕೂಡ ಸಾಕಷ್ಟು ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಕಂಡು ಬಂದಿದೆ. ನೌ ಹರ್ ವೇಟ್ ಇಸ್ 36 kg. ಸೊ ಈ ರೀತಿ ನಾವು ಮೆಡಿಕಲ್ ಇಂಟರ್ವೆನ್ಷನ್ಸ್ ನಾವು ಮಾಡಿದ್ವಿ. ಜೊತೆಗೆ BTB ಪ್ರಾಜೆಕ್ಟ್ ನಿಂದ ಶ್ರೀ ರಾಮನಗೌಡ ಪಾಟೀಲ್ ಅಂತ ಇದ್ದಾರೆ, ಅವರು ನಾನ್ ಕ್ಲಿನಿಕಲ್ ಸಪೋರ್ಟ್ ಗೆ ಸಾಕಷ್ಟು ಎಫರ್ಟ್ ಮಾಡಿದ್ದಾರೆ. ಅವರು ಕೂಡ ಇದ್ರ ಬಗ್ಗೆ ಸ್ವಲ್ಪ ಮಾತಾಡ್ತಾರೆ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನನ್ನ ಹೆಸರು ರಾಮನಗೌಡ ಪಾಟೀಲ್. ಕರ್ನಾಟಕದಲ್ಲಿ ಬೆಳಗಾವಿ ನಗರದಲ್ಲಿ KHPT ಕೋಆರ್ಡಿನೇಟರ್ ಅಂತ ಕಾರ್ಯನಿರ್ವಹಿಸ್ತಾ ಇದ್ದೀನಿ. ಮೊದಲ ಬಾರಿಗೆ ನಾವು ಪೇಷಂಟ್ ಮನೆಗೆ TBHU ಜೊತೆ ಭೇಟಿ ನೀಡಿದ್ದು. ಆ ಸಂದರ್ಭದಲ್ಲಿ ಪೇಷಂಟ್ ಬೆಡ್ ರಿಡನ್ ಆಗಿತ್ತು ಮತ್ತು ಮಾನಸಿಕವಾಗಿ ಕುಗ್ಗಿದ್ದರು. ಅವರು ಪೇಷಂಟ್ ಮತ್ತು ಅವರ ಕುಟುಂಬದ ಜೊತೆ ನಾವು ಆಪ್ತ ಸಮಾಲೋಚನೆ ಮಾಡಿದಾಗ ನಮಗೆ ತಿಳಿದ ಬಂದ ವಿಷಯ, ಅವರು ಮಹಾರಾಷ್ಟ್ರದಲ್ಲಿ ಇದ್ದರು. ಅವರ ಪೇಷಂಟ್ ಗಂಡ ತುಂಬಾನೇ ಮದ್ಯಪಾನ ಮಾಡ್ತಾ ಇದ್ರು ಮತ್ತು ಮಾನಸಿಕ ತೊಂದರೆ.
Raman Gowda avare, all those things have been repeated. Actually, if you can go directly to your point, I think it will save time, Raman Gowda. Is that okay?
ಸರ್, ನಾವು ಭೇಟಿ ಆದ ಟೈಮ್ದಾಗ ನಮ್ಗೆ ಮಂತ್ಲಿ ಬರೋ ಟೈಮ್ದಲ್ಲಿ ಅವ್ರಿಗೆ CSC ಮೀಟಿಂಗ್ ಬರ್ಲಿಕ್ಕೆ ನಾವು ಹೇಳಿದ್ರು. ಡಿಸೆಂಬರ್ ತಿಂಗಳಲ್ಲಿ ಅವ್ರಿಗೆ CSC ಮೀಟಿಂಗ್ ಭಾಗವಹಿಸಿದ್ರು. ಅಲ್ಲಿ ಆನ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮತ್ತು ಟ್ರೀಟ್ಮೆಂಟ್ ಕಂಪ್ಲೀಟ್ ಆದವರು ಅವರ ಅನಿಸಿಕೆಗಳನ್ನು ಹಂಚಿಕೊಳ್ತಾ ಇದ್ರು. ಅವಾಗ ನಾನು ಬದುಕಬಲ್ಲೆ ಅನ್ನೋದು ಅವ್ರಿಗೊಂದು ಛಲ ಬಂತು. ಮತ್ತು ಆತ್ಮಸ್ಥೈರ್ಯ ಮತ್ತು ಆತ್ಮಬಲವನ್ನು ಅವ್ರಿಗೆ ಹೆಚ್ಚಾಯಿತು. ಅದರಿಂದ ಇವ್ರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನು ಇದನ್ನ ಮಾಡ್ಲಿಕ್ಕೆ ಗುಳಿಗೆಯನ್ನು ಟೈಮ್ ಟು ಟೈಮ್ ಗುಳಿಗೆ ತಗೊಂಡು ಅವ್ರು ತೊಗೊಳಕ್ ಚಾಲು ಆದ್ರು. ಅದನ್ನು ಮತ್ತು ಅಲ್ಲಿ ನಾವು CSC ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ಪೌಷ್ಟಿಕ ಆಹಾರ ಮತ್ತು ನ್ಯೂಟ್ರಿಷನ್ ಪೌಡರ್ ಬಗ್ಗೆ ಕೊಡಲಾಯಿತು ಮತ್ತು ಅವ್ರಿಗೆ ಹೇಳಲಾಯಿತು ಅದ್ರ ಬಗ್ಗೆ. ಮತ್ತೆ ಅವರು ಒಂದು ಕುಟುಂಬದಲ್ಲಿ ಆರ್ಥಿಕ ಸ್ಥಿತಿ ಇದಾಗಿದೆ, ಅವ್ರಿಗೆ ಒಂದು ಜಾಬ್ ನೀಡಿತ್ತು. ಅವರು ನಾವು ಒಂದು ಇಂಡಸ್ಟ್ರಿಯಲ್ಲಿ ಅಲ್ಲಿ ಅವ್ರಿಗೆ ಭೇಟಿಯಾಗಿ ಬೆಳಗಾವಿ ಚೇಂಬರ್ಸ್ ಆಫ್ ಕಾಮರ್ಸ್ ಅವರಿಗೆ ಭೇಟಿಯಾಗಿ ಅವ್ರಿಗೆ ನಾವು ರಿಕ್ವೆಸ್ಟ್ ಮಾಡಿದ್ವು ಇವ್ರಿಗೆ ಕೆಲಸ ಸಲುವಾಗಿ. ಅವರು ಈ ಲಾಕ್ಡೌನ್ ಮುಗಿದ ನಂತರ ಅವ್ರಿಗೆ ಒಂದು ಕೆಲಸ ಕೊಡ್ತೀವಿ ಅಂತ ವಿಶ್ವಾಸ ಹೇಳಿದರು. ಮತ್ತೆ ಅವ್ರಿಗೆ ಒಂದು ಆರ್ಥಿಕ ಸ್ಥಿತಿ ಇರೋದ್ರಿಂದ ಅವ್ರಿಗೆ ಒಂದು NGO ಮುಖಾಂತರದಿಂದ ಒಂದು ರೇಷನ್ ಮತ್ತು ನ್ಯೂಟ್ರಿಷನ್ ಪೌಡರ್ ಅನ್ನು ಕೊಡಿಸಲಾಯಿತು. ಮತ್ತು ಅವರು ಮಹಾರಾಷ್ಟ್ರಲ್ಲಿ ಇರೋದ್ರಿಂದ ಮಕ್ಕಳ ಎಜುಕೇಶನ್ ನಿಂತೋಗಿತ್ತು. ಅವರು ನಾವು ವಡಗಾಂವದಲ್ಲಿ ಸ್ಕೂಲ್ ಹೆಡ್ ಮಾಸ್ಟರ್ಗೆ ಭೇಟಿಯಾಗಿ ಅವ್ರ ಬರೋ ಸಾಲಿನಲ್ಲಿ ಎಜುಕೇಶನ್ ಅನ್ನು ಅವರು ಪ್ರವೇಶವನ್ನು ಕೊಡ್ತಾನಂತ ಅವರು ಹೇಳಿದರು. ಮತ್ತೆ ಅವರು ಇವಾಗ ಅವ್ರಿಗೆ ಮಕ್ಕಳ ಎಜುಕೇಶನ್ಗೆ ಒಂದು NGO ಅವರಿಗೆ ಸಹಾಯ ಮಾಡಲಿಕ್ಕೆ ಮುಂದೆ ಬಂದಿದ್ದಾರೆ ಮತ್ತು ಇನ್ನ 15 ಅವರು ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನು ಕಂಪ್ಲೀಟ್ ಆಗುತ್ತದೆ ಅಂತ ಹೇಳಲು ಬಯಸುತ್ತೇನೆ. ಈ ಕೆಲಸ ಮಾಡಕ್ಕೆ ನನಗೆ ಆತ್ಮತೃಪ್ತಿ ತಂದಿದೆ. ಧನ್ಯವಾದಗಳು.
Thank you, ma'am.
Thank you, Raman Gowda, and thank you, Parshuram, for sharing the current situation which you are handling and a very powerful story that you have shared with us. Excellent. And as you are aware, in this story, they brought out domestic violence. They also brought out divorce, where the woman was divorced by her husband, despite financial crunch. The department under WCD, she has been given the benefits of the scheme, and also she was her child was supported. And then the Malika was talking about collective power. The care and support group meetings have given the power to voice and probably get the counseling, right kind of counseling. That was an excellent example, Raman Gowda and Parshuram. Thank you very much. And now I invite Dr. A. Rajeshan from Telangana to speak his experience, field experience. Over to Dr. Rajeshan.
Good afternoon, everybody. First of all, I'm very much thankful to the KHPT and USAID for giving me this opportunity to participate in this webinar. As our eminent speakers told, gender responsiveness and stigma redressal are the two major components which need to be addressed if we want to achieve our goal of ending TB by year 2025. So without wasting much time, I will go to Telangana experience. Stigma at the individual level, in my perception, it can be tackled by listening to the patient with empathy and providing emotional support and creating awareness about TB and telling her that or him that TB can be occur to any patient, any type of patient, like whether he is rich or poor or male or female, whatever is the age. So with this creating awareness about TB, we can, by listening sympathetically with the patient, we can reduce the stigma among the patients. So coming to our Telangana experience, during the community engagement events in Telangana state, we stress more on stigma. So because ignorance of TB may be one of the major reasons for the stigma. So TB can be eliminated only when the community starts talking about TB. If we talk less, the stigma will be more. So the state developed a specific module for community level awareness, which we call it as a Disha TB. This is is it visible?
No, sir.
No, video.
Still not visible.
Samidani, 1 minute. You more like one?
While it's loading, just want to say thank you to everybody. I know we are up by 15 minutes. We hope to wrap up in another 2-3 minutes. I know we've hit lunch.
More.
So as soon as Sir shares, we'll close out within 3 minutes from them. Thank you.
No problem. So we developed a specific module, we call it Disha TB, DISHA, Directed Initiatives for Sustainable Health Action, TB. So Disha TB, it's a module for training purpose to train the TB survivors. We call them as TB champions. We trained them across the Telangana state. Almost more than 200 TB survivors, including female TB survivors, trained as a TB champions, and we regularly use their services to talk on TB during the community engagement events in the Telangana state. We created a pool of TB champions from every nook and corner of Telangana, from each district level and sub-district level TB survivors, and they will be involved in the local areas, in their area only. This, from each TB unit, we have identified 2 TB survivors and we trained them at the state level with this module. And we are using these services in their area, So while we conducting a community engagement meeting in a particular village, these two survivors, they come and they share their experience and then talk about TB, all those things. So coming to gender issues, the consequences of TB may be harsher for women and girls. Women patients are often at risk of divorce or marital breakdown, etc., as our eminent speakers told. So women with TB are also often concerned about reduced chance of marriage, rejection by husbands, and harassment by in-laws, etc., and abandonment from the families, etc. So diagnosis of TB, women may have a longer period of delay before diagnosis. Some possible reasons for this are so many. So Telangana state has taken many steps to improve gender responsiveness. We have created almost more than 12,000 TB clubs in the entire Telangana state in a Gram Panchayat level. In all these TB clubs, all women public representatives are the members, in addition to our ASHAs and ANMs, including these two TB survivors in that TB club. So women TB champions are also trained during this Disha training at state level. And in fact, one of our women TB champion got appreciation from Honorable Governor of Telangana recently. So major challenge for women availing TB services could be the distance to be covered and restrictions in their physical mobility, etc. So while talking about this stigma and gender responsiveness, we can overcome these barriers with the help of NGOs and others. We can overcome all these things and we can achieve our goal of end TB by 2025. Thank you for giving this opportunity.
Thank you very much, sir. And you have brought out the fact that while like we need to listen to them and empathetic, being very empathetic and to provide emotional support is crucial. And also getting the TB survivors speak with the prospective TB patient. That's an excellent approach, sir. And going forward, thank you very much, sir, for sharing your experience from the field. And now it is time, since we have been speaking from 11 o'clock. Now it is the time to multiply our efforts. Probably I feel that each one of us have a role and it is a shared responsibility. We need to ensure that no one will be affected by TB stigma ever again. Thank you. And thank you, Sukruti. Over to Sukruti.
Thank you, Mamta, and thank you to all the teams. It's such a pleasure to hear the examples from the field and learn from them. I'm going to now firstly thank everybody again for your patience and turning to Dr. Rehana to sign us off with a vote of thanks. Thank you, Dr. Rehana. Over to you.
Yeah, thank you, Sukruti. A very good afternoon to everyone. As highlighted by Dr. Karthikeyan in the chat, I want to reiterate that KHPT is committed to actively working with CTD and STOs to operationalize stigma redressal and gender responses. Breaking the Barriers teams in Assam, Bihar, Telangana, and Karnataka are committed to this. And today's webinar has had about 160 plus attendees. We really appreciate all the people who took the time out of their busy schedules to attend the webinar. The webinar was very knowledgeable and thought-provoking. It was really inspiring to hear Dr. Nishant Kumar's keynote address and emphasis on Jan Andolan and gender equity. The discussion on stigma, discrimination, and global best practices were full of knowledge. It was interesting to listen to KHPT's experiences and state-specific stories from the field, which gave a deep insight into today's topic of discussion and also revealed some interesting facts. I hope you all had a wonderful opportunity to be a part of the discussions. I'd like to thank Dr. Nishant Kumar and the CTD team for the ongoing support and key remarks at this webinar. Another big thanks to all our panelists, Ms. Amrita Goswami, Dr. Uman George, Dr. Dalveer Singh, Ms. Blessina Kumar for enlightening us with their knowledge. And thank you to Dr. N.J. Das, Dr. B.K. Mishra, Dr. A. Rajesham, Mr. Parashuram Patil, Mr. Ramanan Gowda Patil for the state-specific sharing. You all have really made this event interesting. I would like to refer to what Dr. Nishant Kumar said, that you all are the real crusaders in the fight against TB. Finally, most importantly, I would like to thank the KHPT team led by our CEO, Mr. Mohan, as well as Dr. Pratna, Ms. Malika, Ms. Mamta, Dr. Kartikeyan, Dr. Sukruti, Ms. Vrinda, and Ms. Shramana. Without your continued support, we would never arrange such events like this. So thank you. Have a great day, everyone. Stay safe and healthy. Goodbye for now.
Thank you so much, everybody. Have a good day.